بسم الله الرحمن الرحيم. السلام عليكم جميعا. Good evening everybody. Today is the first day of our revision. We'll start by anatomy revision. We have two mocks, one today and the second one will be inshallah tomorrow. Honestly, you will have at least 90 or 95% of anatomy mock in your exam. Today will be updated by some pictures which came before in real exam. The most difficult thing you will find in anatomy in your exam, identification. So the station will go exactly like we will discuss today, except identification sometimes will be difficult or you will have some new pictures. Don't be panic about this, okay? This is the first point about this mock. Also, I wanted to tell all of you that all my materials are outside, except mocks. All our materials of part B are outside, except mock. So mocks now between your hands. If you want to get outside, okay, do it. But trust me, exam will start to be more difficult. This is what I wanted to tell you. I will not tell anybody, you should be honest, is this not your right? No. If you want to give to your friend, give it. Give it. But you have people here, they suffered to save money for this discussion or for this course. And you are simply distributing these materials. Okay. After finishing of anatomy today, you will find recording will be in MOOCs group, and notes will be in February. I shared it now. In February and March group. Notes related for the MOOCs. So please, if you are not in these groups, send for Shinoda or Suzanne to add you. You can start now, Dr. Maria.
Hello, good evening, everyone. So we are Dr. Muhammad and Dr. Bruno. Are you ready?
Yes.
Yes, I think so.
Okay. So we will start the first station. We will start with one question for Dr. Bruno, then one question for you, Dr. Muhammad. And alternatively, we will go all the way. Okay?
Okay.
Okay, so the first question, can you please identify the this side of the clavicle? Is it the upper side or the lower side?
This is the lower side.
Okay, can you tell me where is the sternal end? Which number?
Number 5 is sternal end and 1 is shoulder end.
Okay, perfect. And can you tell me how it articulates with the scapula?
The shoulder end will articulate with the acromion of the scapula.
Okay, perfect. Okay, Dr. Muhammad, can you please identify the spine of the scapula?
Spine is number 10.
Okay, and what about the acromion?
Acromion is number 2.
What about the coracoid process?
Number 3.
Okay, perfect. Okay. Just a second. Can you please identify the supraspinatus muscle? Can you point at it? Or you can tell me where it is.
For me,
Supraspinatus is the above, the upper one.
Here?
Above the
Yes.
pen. Yes.
Okay, and what about the one below the spine?
The below the spine is infraspinatus.
Okay. And what about the teres minor?
Teres minor is the below the infraspinatus, which is going upwards to the, yes.
Okay. Can you tell me the origin and insertion of each muscle of them?
Supraspinatus origin is the supraspinatus fossa of the scapula. Infraspinatus origin is the infraspinatus fossa of the scapula, and teres minor origin is the lateral border of the scapula, and all of these insert into the greater tuberosity of the humerus.
Okay. What are the stabilizers of the synovial joint in general?
it can divide it to the static stabilizer and dynamic stabilizer. Static stabilizer like bony articulation, fibrous capsule, ligaments and tendon, and also negative pressure inside the joint. Dynamic stabilizer muscle around the joint.
Okay, perfect. Next question, what's the main stabilizer of the shoulder joint?
The rotator cuff muscles.
Can you identify the greater tuberosity on this picture?
Greater tuberosity is number 3.
Okay, Dr. Broma, can you identify the anatomical and surgical neck?
The anatomical neck is number 1 and number 10 is surgical neck.
Okay. Can you, Dr. Muhammad, can you tell me the movements at the shoulder joint?
It is flexion, extension, abduction, adduction, internal rotation, external rotation, and circumduction.
Okay. You will be asked in the exam either to show it on yourself or there will be an actor that you show the movements on them. Okay.
Okay.
Can you identify the green muscle and tell me the function of the clavicular and the sternal part of the muscle?
Okay, this is pectoralis major muscle, and function is adduction and medial rotation of the muscle, and the clavicular head is flexion of the shoulder joint, and the function of sternal part is extension of the flexed shoulder joint.
Arm. Okay.
Yes, arm.
Does it have any additional function, Dr. Muhammad?
Yes, it is an accessory muscle of respiration.
Okay. Can you tell me the function of the deltoid muscle?
Yes.
Yes, Dr. Broma.
Yes. The anterior fiber is medial rotation and flexion. The posterior fibers, external rotation and extension, and the middle fibers are main abductor of the shoulder joint above 15 degrees.
Okay. Dr. Muhammad, can you tell me which muscles is responsible for flexion of the elbow?
The biceps brachialis, brachioradialis, brachialis, prominentis, also flexor radialis.
Okay, can you, Dr. Bruma, can you tell me where the humerus head is? Which number?
It's number 8.
Okay, Dr. Muhammad, what about the glenoid?
Glenoid is number 6.
Okay, next, Dr. Bruma, what's the acromion? Where is the acromion?
It's number 1.
Okay. Supraspinatus.
Supraspinatus muscle is 9 and tendon is 10.
Deltoid muscle.
It's number 5.
Okay. This is the last question I have in this station. Great job, both of you.
Okay. Yeah, they did great, by the way. Okay, go back, Dr. Maria. Go back. No, second. This new picture, by the way, I received it. They told me this is exactly the picture came in exam. Just recent in Cairo. This is the new picture came last time. So please keep it. I shared it in the group also. We'll ask you about identification of the rotator cuff muscle. Okay, I have a question. Which joint responsible for shoulder abduction? Okay. Could you answer?
Dr. Muhammad or Dr. Bruma, does anyone know the answer?
Shoulder joint and also rotation of the scapula is responsible for shoulder abduction above 90 degrees.
Already answered in the chat.
Yes.
Okay.
Glenohumeral and scapulothoracic.
Yes. No, he is asking what is the name of shoulder joints for abduction. This was new question. Otherwise, all the questions are the same.
Okay.
All the questions are the same. Nothing new. Like every time I'm talking about this station, about more than 50% of you will not reach till the end of this station. Okay, because you know the end of the station by the MRI picture. All of our candidates they told it is the same. This is I will write this question. Look for notes group, you will find it. Now it's in the notes group. This new question. Okay. Shoulder anatomy. Examiner asked me about joint of abduction. I answered glenohumeral joint. He said, what else? He's waiting scapulothoracic joint. Okay, these two joints. As I told you, to reach for the end of this station, yani from the beginning, I will find the scapula, clavicle, asking to articulate. I know this station will end by MRI. So I warned our candidates about this station. If this will come in the first day of Cairo last time, I told them, if this station will come, try to run. You know what happened? انت فاكر اللي حصل؟
Yes, most of the people didn't finish the station.
No, when he did
Very...
nice thing, you know what I think? He's answering the question before. He told me, I want to finish. Oh my God. You want to finish? So you answer the question before he's asking. Examiner told him, he's from UK. He told him, you know the station? How you know it? So don't do these big mistakes. Try to act like them. Okay, yalla, next station.
Okay, next we have Dr. Nidal and Dr. Shami. Dr. Nidal, if you're here, can you please raise your hand and unmute yourself?
يعني انت حاطه كل الابديتس يا مريم، مش سايبه لي حاجه اقولها بس برضه
لا
لسه.
خالص يا دكتور صلاح.
لا
خالص بالعكس.
مش عايزين نتكلم، حاطه كل الابديتس.
ما نستغناش يا دكتور صلاح، حضرتك عارف. دكتور نضال. I don't know, the one who chose the station.
We have one female and one male.
Okay, whoever chose the station, please raise your hand or write in the group that this is you. Okay, the stem for this station is a patient who came in an RTA with a suspected neck and shoulder injury. Okay, we will start with Dr. Shaiman for the first question, then we will go for Dr. Nidal for the second question. Is that okay?
Yeah. Okay.
Okay, so the first question is,
Wait, sorry. In previous station, we discussed about the question. What is the other movement when you will do shoulder abduction? What is the movement? What is the additional movement will be done when you will do shoulder abduction?
No, there is another station for the shoulder as well. It's added to that area.
Maybe. Yes, rotation. It's a lateral rotation of humerus or scapula. Lateral rotation of humerus or scapula. Upward or lateral rotation of the scapula. This is the other movement. I think this question is rotation asked by this way. Okay, so better to add this question with you also. اكتب عندك عشان ما تنساش لو يلا next.
Okay, so what is the injury that you would suspect?
Brachial plexus injury.
Okay, perfect. Which part of the brachial plexus in particular? Which common trunk to be injured?
This is the upper trunk root of.
One question for you and one question for her. Okay.
Okay.
So, Dr. Nidal, your answer is?
Yes, it is the upper trunk, C5, C6.
Okay. Next question. C5 will exit in between which two vertebrae?
C4, C5.
Okay, next question. Where they arise from at the vertebrae?
This is the intervertebral foramina.
Yes.
Yeah.
And there will be a picture for the vertebrae, or there will be a real vertebrae, and he will ask you to point at the place that the nerve pass exactly.
Okay.
Okay. Can you tell me C5 and C6 cutaneous supply?
The C5 supply a lateral part of the deltoid, and the C6 supply a radial part of the forearm till the sun.
Okay. Can you describe Erb's palsy?
Yes, Erb's palsy, it is the upper nerve root affection is C5 and C6. Patient came has the arm adduction and medial rotation, also forearm pronation and extension.
Mhm.
Also sensory affected lateral arm and lateral forearm.
Okay. And next question, Klumpix paralysis. Can you describe it?
Yes.
Dr.
Patient.
Shaimeh.
Okay.
Okay, it is injury of lower trunk of brachial plexus, C6, C8, T1, which leading to clawing of the hand deformity and losing of the sensation in the ulnar side of the arm and forearm and hand.
Okay.
Yes.
Just a second. Okay. Can you identify the rotator cuff muscles and tell me the, we already said this question, the nerve supply? Say the
Yes.
name of the muscles and the nerve supply of each.
Yes, we have supraspinatus and infraspinatus. This is by suprascapular nerve. We have teres minor for axillary nerve. Also, we have subscapular. This is for subscapular nerve, upper and lower.
Okay. Can you tell me, next question, the origin and insertion of the deltoid muscle and how you test it on the actor?
The origin of deltoid in the lateral half of clavicle and scapula, and inserted into deltoid tuberosity of the humerus. The nerve supply of it is axillary nerve, and can test it by asking the patient to doing abduction at the shoulder and
At which level?
from 50 to 90 degrees.
Okay, perfect. Next question, what are the flexors of the elbow and their nerve supply?
Yes, we have brachialis, brachii, brachioradialis, pronator teres, flexor carpi radialis. Flexor carpi radialis and brachioradialis, this is by radial nerve. Pronator teres by medial, brachialis and biceps, this is by musculocutaneous nerve.
Can you tell me the name of the musculocutaneous nerve in the forearm?
It is lateral cutaneous nerve.
Okay. Next question. Can you show how you do the reflex of the biceps, triceps, and the supinator on an actor? Just describe what you would do.
Okay, in biceps reflex, we're doing flexion of the arm at 90 degrees and identify the biceps tendon. Put your finger and hammer over it.
Okay.
The reflex will appear on biceps contraction. And the triceps reflex, we do it in the posterior part of arm. Identify a triceps tendon and tap directly over it. And supinator reflex, identify in the four fingers above the wrist joint and hammer over it.
Okay. Next question, what is the sensory distribution of the ulnar nerve in the forearm?
In the forearm, it is the medial side forearm. This forearm, complete to hands or just forearm?
No, complete the hand as well.
Yes. Also, we have medial or medial arm, medial third of the arm. Also, the two finger, one and a half, one and a half finger. This is the medial.
Which fingers?
This is the medially.
Medial. Okay. Yeah. What about the radial nerve, Dr. Shaimeh?
It is supply the dorsal and lateral 2/3 of fingers, 2/3 of hand, and the lateral 3.5 finger, the dorsal aspect, except the tip of them.
Okay, and what about the median nerve?
Yes, median nerve supply 2.5 third of the palm, and also 3.5 finger laterally. Also the digits of the thumb, second and third upper digits.
The last one is what?
What?
What did you say? The last one? I didn't hear.
The digits.
Digits. Oh, okay. Okay, next question. Can you tell me the rotators of the scapula, origin and insertion and nerve supply?
Okay, the inward rotation is by rhomboid major and minor. It is supplied by dorsal scapular nerve. And outward rotation through trapezius.
What about the origin and insertion?
Okay, the rhomboid major arising from spinous process of T5 to T, I don't remember.
Okay, what about the upward rotation?
The outward rotation through the trapezius and serratus anterior.
Okay, what's the origin and the nerve supply?
The trapezius origin from spinous process C7 till T12, and the occipital and the occipit and knuckle ligament.
Yes. So
Yes,
the trapezius from C7 to T12, the occipital protuberance, as you said, the knuckle ligament, and where is it inserted?
Inserted in the clavicle, scapula, and acromion and spine.
Okay, and what about the nerve supply?
Supplied by spinal accessory nerve.
Okay, and what about the serratus anterior?
It is originated from ribs.
1 to 9.
Which ribs?
1 to 6,
9.
1 to 9, and inserted into scapula.
Okay, and what's the nerve supply?
It is supplied by long thoracic nerve.
Okay, so you're only missing the rhomboids.
Yes.
Dr. Shaima, do you know the origin, insertion of it?
Me?
Yes.
Yes, from this is the minor from C7 to T1.
Yes.
Major from T2 to T4.
Perfect. And the insertion?
Insertion in the scapula.
The medial border of the scapula, yes.
Medial border of scapula.
Okay. Demonstrate the brachioradialis muscle action on yourself and the nerve supply.
Yes, brachioradialis flexed the forearm, flexed elbow joint. So this is by radial nerve.
Okay, perfect. I think this is the last question, and you both did a great job.
Thank you.
Dr. Salah, do you have any comment?
Yes, still go back.
حاضر.
Okay.
Yeah.
Horizontal group. Yes. Okay. First question about the herpes and the Clombex. Demonstrate in yourself. You know how to do it in yourself?
Yes.
You know how to do this movement? Because the update of this station, everything about herpes and the Clombex asked. So first, which root will be affected? As you know, herpes for upper, so C5, C6, Clombex is lower, so C8, T1. Demonstrate in yourself how to do herpes and the Clombex, very important. Herpes, like you see in the picture, which you named water hip deformity. While Clombex, it will be clawing of the hand. Then he asked, what is the causes of both of them, herpes and clumps? Answer.
What? Sorry?
Causes for herpes palsy or clumps paralysis. Mechanism.
Earth palsy, traction fracture, hyperextension of the head and neck away from the shoulder. This is the earth palsy, I think.
What else? So causes of herpes palsy like cephalopelvic disproportion, forceps delivery, victim injury, if you will also deliver by victim, breech presentation, force or pulling the arm. Okay, this regarding or herpes. Clumps. Caused by what?
I don't know.
cervical rib. يا شباب اللي عنده نويز باك جراوند، مين اللي عنده نويز باك جراوند يا ماريا؟
عارفة ما they're all muted.
اوكي واحد منهم اوكي. For clumps confined like cervical rib, also if difficult delivery, and also scalene muscles. Scalene muscles can be. Okay, come now for nerves. Okay, about. I shared it in the group already. Everything is shared. So all the notes I shared already in the group. About nerves, what is the sensory distribution of ulnar nerve, median nerve, and ulnar nerve, and the radial nerve? Last answer.
And the nerve from the medial forearm.
No.
This is okay.
Medial forearm from where?
Below the elbow. Till
My coach, listen.
Yeah.
Medial forearm from where? Nerve. What is the name of the nerve? Medial cutaneous nerve of the forearm.
Yeah. Okay.
Arm and the forearm medially. Medial cutaneous nerve of the arm. Medial cutaneous nerve of the forearm. Ulnar nerve, not forearm. So again, what is the cutaneous supply of the ulnar nerve? Again. الالنر نيرف بيدي ايه؟ سؤال سهل. انت
medial 1.5
انا عايز
finger.
اجاوب يعني this is very easy. يعني الالنر نيرف هي جاوبته على فكره، هي جاوبته. What are you؟
Yes. أنا.
ايوه قولي لي الالنر نيرف بيغذي في الهاند بس.
medial 1/3 digits and half digits.
Medial 1/3 of the palm and medial 1.5 fingers or digits. Medial 1/3 of the palm and the medial 1.5 fingers. Okay. يلا كمل بعده. And also and covering dorsally also. يعني this is palmar and then dorsal. Okay. So medial nerve.
Median nerve 3.5 lateral finger. Also palm 2.3 lateral palm. Also the digits, upper digits of the thumb, index and middle.
ما انت قلتي lateral 3.5.
Yeah.
So lateral 2/3 of the palm, lateral 3.5 digits. This is for palm. For dorsal.
Digits.
Tip.
Yeah, tip. Okay.
What about the remaining of the dorsal? By which nerve?
By radial.
خلاص هي radial nerve, sensory ovidic nerve.
First web space and the rest of the dorsum except area of the ulnar.
What else?
What else? It is the lateral arm.
Lateral arm.
Also, joints of the wrist joints are called. Not remember now.
Sensory. Okay, I agree. The remaining of the dorsum of the hand. okay, which are the remaining 3 dorsal 3.5 fingers except the tip, which is supplied
Yeah.
by me. This is the first anatomical snap box or anatomical snap box, and area at the lateral of the arm, lower lateral of the arm by radial nerve, while upper
Yeah.
by axillary, and the posterior forearm.
Yes.
You know, the lateral layer of the arm, you have branch of radial nerve named lower lateral cutaneous nerve of the arm. This from radial. Posterior of the arm, posterior cutaneous nerve of the arm. Posterior of the forearm, posterior cutaneous nerve of the forearm. While the superficial branch of radial supplying the remaining of the hand. Clear?
Yes.
Yalla. I think station finished by this way. Sensory distribution not important by this way, but you should keep it. You should know. You don't know what will happen in exam. You don't know what will happen in exam. I shared already the pictures with you. I shared it in the group. Yalla, Dr. Maria, next station.
Okay, so who's next? Dr. Omar and Dr. Tadros, can you please guys all raise your hand? Okay, and unmute yourself.
Good evening, everybody.
Good evening, Dr. Omar. Dr. Tadros, can you please unmute yourself?
Good evening.
Good evening. Okay, so we will start with Dr. Omar, one question for you and one question for Dr. Tadros and go on, okay?
Okay.
All right, first question, can you please identify structure number 2?
Is the stomach?
Okay. Next question, can you identify parts of the stomach by numbers?
Number 6 is fundus. Number 2 is the body. Number 18 is pyloric antrum. 19 is pyloric canal.
Okay. Can you please identify the blood supply of the stomach?
Yes, it have the short and the right and left short, the right and left gastric arteries. The left is from the celiac trunk.
Okay, so let's agree that you will tell me which part is supplied by which artery and the source of this artery.
Okay, the left and the right artery, gastric arteries, is the lesser curvature of the stomach. The right and left gastroepiploic arteries.
No. Just a second.
Yeah.
So the left gastric, where is it originated from?
It's originated from the celiac trunk.
Yes, and the right gastric, where is it from?
The right gastric is from the common hepatic artery, which is from the celiac.
Okay, so this is how your answer should go. So the lesser curvature is supplied by the left gastric, which is originated from the celiac, and the right gastric, which is originated from the hepatic.
Okay.
Continue on the same sequence. The
Okay.
greater curvature.
The greater curvature is the left gastroepiploic artery, which is originated from the splenic artery, and the right gastroepiploic artery, which is originated from the gastroduodenal artery.
Okay. What else?
The short gastric arteries, which is originated from the splenic artery.
It supply which part?
It is supplying the fundus part.
Okay, perfect. What else?
I don't remember.
What about the pylorus?
The pylorus. I think it's supplied by the gastroduodenal artery.
Perfect. It's supplied by the gastroduodenal artery from where?
The artery which is from originated, you mean?
Yes.
It's originated from the common hepatic artery.
Okay, next question. Dr. Tadros, can you please identify the pancreas? Which numbers?
Number 9.
And
number 3 and number 16, tail of pancreas.
Also the question for you, Dr. Tadros, can you describe the development of the pancreas?
From the ventral bud and dorsal bud. Ventral bud from the hepatic diverticulum and dorsal bud from the dorsal part of the duodenum.
Okay, and the ventral bud gives which part of the pancreas?
The ventral part gives a synaptic process and lower half of the head, and the dorsal bud gives the upper part of the head and the remaining of the pancreas.
Okay. Next question, what is the peritoneal relation of the pancreas?
From posteriorly is the superior.
No. I mean the relation of the pancreas to the peritoneum.
Okay. Is retroperitoneal, just the tail, which is intraperitoneal.
Exactly. Okay, next question. What's the blood supply of the pancreas? Dr. Tadros, and please, the answer is the same way as we said the stomach.
Superior pancreaticoduodenal from the gastroduodenal from the common hepatic, inferior pancreaticoduodenal from the superior mesenteric artery, and pancreatic branches from the splenic artery.
Yes, these supply which part?
Superior pancreaticoduodenal and inferior pancreaticoduodenal from the to the head. Splenic branches into the pancreatic to the remaining of the pancreas. Body and tail. Sorry.
You mean pancreatic branches from the splenic artery?
Yeah.
Okay. Pancreatic branches from the splenic artery for the body and the tail. Okay. Next question. Can you please describe the ductal drainage system of the pancreas?
It have two ducts, which is the main duct. It's called the Wersing duct. It's opening at the ampulla of water in the second part of the duodenum, in the posterior medial aspect of it, and the accessory one.
The accessory one drains which part?
The accessory one is the drain the uncinate process.
And it opens where?
It's have a variations. I think it may have open in the ampulla of water, or below the opening in the second part of duodenum.
In the minor duodenal pupil.
Oh, okay.
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 Okay. Next question. What is the vessel present behind the body of the pancreas?
Splenic vein.
Okay. Next question. What's the space between the pancreas and the stomach?
Lesser sac.
Perfect. What is next question? The vessel present behind the neck?
Portal vein.
Okay. And it unites with what to form what? Sorry, it's formed of the union of what?
Superior mesenteric vein and splenic vein.
Okay. Next question, the peritoneal relation of the duodenum.
In the back posteriorly is the inferior vena cava.
No, again, the peritoneal relation.
You mean which part is intraperitoneal and which part?
Exactly.
Yes,
this is the meaning of peritoneal relation.
Okay, I get it. So the first part is intraperitoneal. The second, third, and fourth part is retroperitoneal.
Yes, so it's all retroperitoneal except for the first part.
The first part, yeah.
Okay. Next question, the vessel present in front and behind the third part of the duodenum.
In front of the third part is the superior mesenteric vessels. Behind it's inferior vena cava and aorta.
And the right gonadal vessels.
The right gonadal veins. Sorry.
Okay. Last question. In which part of the peritoneum the hepatic artery pass?
Lesser omentum.
Yes, exactly. This is the last question. Great job for both of you. Dr. Salah, your comments.
Okay, wait. I think the last question was one of the updated questions about in which part hepatic artery bus. Again, what is your answer?
The lesser omentum.
Okay. How celiac trunk supplies the stomach?
I get it. I didn't get it. Please, can you repeat your question?
How celiac trunk supplies stomach?
Yeah. So it's give the left gastric artery. It's supply the lesser curvature in the left side, and then it's give the common hepatic artery, which is give the gastroduodenal artery that give the right or the right gastric artery.
No. I want it to be more accurate. Yes, you get the answer, but I want to be more accurate. So
As we said, say what we said.
by the left gastric artery on the right gastric.
direct branch from it, which is left gastric, and this is supplied the lesser curvature. Okay.
Yeah.
What else?
The right gastric artery, which is come from the common hepatic artery, which is also supply the lesser curvature.
Okay. What else? You have another branch?
The pylorus, as you asked before, which is from the gastroduodenal.
Like we discussed now, about the blood supply, it will be by sites coming in Cairo by this way. Okay. Dr. Maria asked you about what behind the neck?
Yeah, portal vein.
Formed by what?
Formed by superior mesenteric vein and splenic vein.
What is the inferior mesenteric?
Inferior mesenteric drain into splenic vein.
Okay. Portal vein drain where?
Drain into liver. Into the portal hepatis.
Into the liver. So how will it get rid of his venous?
Sorry?
How liver will get rid of its venous?
Right and middle and left hepatic vein into the inferior vena cava.
Excellent. Yeah, next.
Thank you.
Not 4 hepatics, 3 hepatics, like he told.
Yeah.
I think this is done by this way. Nothing more to be added. Yalla, next, Maria.
Great job, both of you. Thank you very much.
Thank you very much.
Yeah.
Okay, next we have Dr. Hadir and Dr.
Before going, I shared in notes group the station about the herpes palsy. The station of herpes palsy. I wrote it. You will find upper limb skeleton with actor. Yani this station came recently. Sorry, I forgot to tell you that about the herpes palsy. The station done with Dr. Shama, I think, and Dr. Nadal. كانت مع مين اللجنة دي؟
Yes.
Okay. It was upper limb skeleton and actor, and stem was RTA. So what do you suspect injury? First the question. It will go by this way. What do you suspect injury? You should mention brachial plexus injury. Then what is the common trunk can be injured? Upper trunk. Then we'll start to ask you, like Maria asked you, where arise from the foramina, demonstrate the dermatomes of C5, C6, herpes and clumbex, identify supraspinatus muscle, origin insertion nerve supply, deltoid origin insertion, how to test it, deltoid. I think all the questions are like asked by Maria. I shared this station in the group, in the notes group already. This is the update. So this station, don't be panic. You will find the skeleton and the actor. Skeleton and the actor. Before, if no actor, he will ask you to demonstrate on yourself. Herpes and clumbex. So you should train yourself how to do herpes and clumbex by yourself. Yalla, continue, Maria.
Okay, next we have Dr. Hadir and Dr. Manor. So I cannot find Dr. Manor. Can you please raise your hand? Or if the name is incorrect, do let me know. Dr. Mansour. Okay. Yeah, Dr. Mansour, you can unmute yourself now.
انت عارف يا مريم انا سالت السؤال ليه؟ هاو سيلياك ترانك سبلايز ستومك؟
علشان مش كله.
لا مش كده بس.
Mm.
You know what is the problem for many candidates in exam? They know the question and the answers, but when examiner asks the question by another way, you will be stuck.
Exactly.
You will be stuck. It's the same. Blood supply of the stomach,
Yes.
but according to parts, it's the same. But the question asked last time, how electrolyte supplies the stomach. It is the same. So don't be panic.
Okay, Dr. Mansour and Dr. Hadir.
Mansour, raise your hand.
He is here. I am asking him to unmute yourself.
He raised his hand.
Can you please unmute yourself?
Yes, I'm mute already. Hello?
It's unmuted.
Yes, you hear me?
Your
voice is
voice
clear.
is not clear. It's very far away.
What about like that?
Adjust
Can
your
you-
mic and go for
Can you
another.
please
يلا.
adjust? Okay. Just adjust your mic for the next station. Okay, so Dr. Haifa, are you here?
Yeah, I'm here.
انت مش هدير؟
هتقول هيبقى حد تاني. طب تمام.
لا خليك عادي. مش مشكلة. اخبارك عامل ايه؟
الحمد لله.
Dr. Haifa, can you please raise your hand?
انت مسميه نفسك اسمين؟
لا, there are two different people.
طب انت معاك هدير وهيفاء اهيت. يلا يلا يا اخوانا.
أيوة, ما أنا unmute yourself, Dr. Haifa, please.
Hi.
Hello.
Hi, how are you?
I'm good, thank you. So are you guys ready? First question for Dr. Hadir, then Dr. Haifa, okay?
بص دول اصحابي من زمان، بالراحه عليهم المريم اللي عليكم، ادوهم
هو
لجنه سهله.
أنا عملت إيه طيب؟ أنا أصلا يعني كل اللي جان سهلة. Okay. First question, Dr. Hadir, can you identify on the per section the external oblique muscle? Okay. Next question, from which structure does it take origin? Dr. Haifa?
The outer surface of the lower eight ribs.
Perfect. Dr. Hadir, what is the nerve supply of the external oblique muscle?
Ventral rami of lower 6 thoracic nerves.
Okay, T7 to T12.
Total 12.
Can you identify the internal oblique? Dr. Haifa?
Yes. It's number 10.
Yes.
Exactly.
Yes, it is number 10. Okay. Which abdominal muscle has a fleshy fiber that lies anterior to the deep inguinal ring?
Internal oblique muscle.
Yes. Can you identify on this picture the appendix?
It's number 1.
It's actually number 2. Number 1 is pointing to the medial appendix.
Okay.
Or the appendicular artery. So number 2 is the appendix itself.
Okay.
Next, can you identify the cecum?
Cecum 4.
Okay. The terminal ileum?
3.
Terminal ileum?
Is it 3?
No, it's not.
13.
I'm not sure.
Dear, do you know what is the terminal ileum?
Is it 10? No,
It's
No.
15.
15?
Is it 15?
15.
It is
yeah.
15, yes. So what is 10?
Where is 10? Yeah,
You just say. This is 10. What is this?
that the
Um,
artery. Where is the ileocecal artery?
Is it
No,
the
no,
ascending
no.
colon?
It is the ascending colon, yes. So number 15 is the terminal ileum. Number 4 here is the cecum. So it continues as the ascending colon. Okay, and this is the number 2 is the appendix, and number 1 is the appendicular artery, and number 12 is the mesoappendix. You're not requested to know the number 1 and 12. They usually ask about the appendix, and the picture that comes in the exam is not going to be looking like this exactly. It's going to be looking like the other one, like this picture, a posterior view from the back. And you will have to look for the appendix, which is right here. Okay.
Okay.
Wait, Maria, wait. This one of the worst station about identification. So like she told you now, it will not be complete picture like in your left hand now. It will be small, but it will come from back. So you are expecting to look for the appendix on the right side, but concentrate the picture from the back.
Okay.
So you will find appendix in your right hand.
Okay.
In your right hand. Go for your right hand, appendix will be here. And it's very clear, very important. Okay, yalla, continue, Maria.
So who will go next, Dr. Hazir? Can you point to the rectouterine pouch?
Rectouterine pouch is
Which number?
number 8.
Yes, and what is it? It's called? What's the name?
There's a question for me. No, I don't know.
Douglas pouch.
Yeah, Douglas pouch.
So, okay, can you identify the ovaries?
Ovaries.
Mm-hmm.
B.
Which numbers?
B.
Yes, number B, and you already said number
The
A is
other one
the...
is number the pouch. Number B is the ovaries. Number and number L is L, right? J on the other side.
Yes, J on the other side. That's true. Okay, next question. Which dermatomes lies at the level of the umbilicus, and which dermatomes lies at the anterior abdominal wall above this level?
The dermatomes lies at the level of the umbilicus is the dermatomes of T10, and above it are the dermatomes from T7 to T9.
Okay. Next question. In acute appendicitis, why the pain first is referred to the umbilical region?
Because of compression of the nerve T10, which is supplies the umbilicus, the cutaneous part of the umbilicus.
Because they share the same
level.
dermatomes, yes, and the same dermatomes, which is T10.
No, I want a clear answer for this question.
Through which fibers?
Can I answer?
Okay.
Yes.
Because the sensory neurons of the appendix, they accompany the sympathetic nerves joining the T10 spinal nerves.
Sympathetic coming from where? Intercostal or where? Yes, I agree. Sympathetic branches.
Spinal.
Sympathetic branches. Yes, I agree. Sympathetic branches, which is coming and the same level of T10 dermatome. Okay. Sympathetic from where? Continue, Maria.
The names of the fibers.
Continue.
Okay.
اللي هي برايتال بريتونيوم حضرتك تقصد؟
ايوه. But continue.
Just a second.
You finished?
No. There is something wrong with في صفحة راحت ما أعرفش راحت فين. Okay, I will continue the question orally if that's okay.
Yeah, it's okay.
Because I
ايوه
don't know where
احسن
the-
خططهم لا ده اخدوا سكرين شوت ومشيروا.
Okay, next question. In acute appendicitis, as the pain moves to the right iliac fossa, what structure has become involved in the inflammatory process?
The parietal peritoneum.
Okay, next question. Can you name 3 positions in which the appendix mainly lie?
Iliocecal, retrocecal, subcecal, pre-ileal, and post-ileal.
And pelvic. Next question. Why may extension of the right hip exacerbate the pain of the acute appendicitis?
Because the appendix lies adjacent to the psoas major muscle. So when the hip is extended, it irritates the parietal peritoneum.
Next question. Can you name the embryological remnant that should be included in the differential diagnosis of appendicitis? Whose turn?
Oh, yes, my turn. So can you
Yes.
repeat the question, please?
Can you name the embryological remnant that should also be included in the differential diagnosis of appendicitis?
Makers diverticulum.
Yes. Next question. If an open appendectomy is carried out, the external oblique aponeurosis is visualized. In which direction do the fibers run?
Downward, forward, and medially.
Perfect. Next question. Which muscle combines to form the conjoint tendon?
Conjoint tendon formed by internal oblique aponeurosis.
And which muscle combines?
Muscle transverse abdominis. Transversus abdominis.
Yes, transversus abdominis. Next question. The nerve supply, the muscle fiber going to the conjoint tendon may be injured during appendectomy. What is the root value and the name?
It's iliohypogastric, L1.
Are you sure it's iliohypogastric?
Okay, then it's ilioinguinal.
Yes, but the examiner is not going to tell you that.
Okay.
Okay, next question. Which branch of the superior mesenteric artery usually gives off the appendicular and the cecal arteries?
Again,
Which branch of the superior mesenteric artery usually give off the appendicular and cecal arteries?
iliocecal artery.
Ileocolic. Okay, this is the last question I have.
Again, the question you asked about what is embryological abnormality.
I'll name the embryological remnant that should be included in the differential diagnosis of appendicitis.
What is the answer?
Makers diverticulum.
Okay, in May is it part A, September. Part A asked what is the blood supply for this for Mickey. I don't know, but this came in part A. So what is the arterial supply for Mickey?
I don't know.
It depends on the site المفروض يعني.
You don't know? مين اللي كان في May? Who's in May exam? قلت له intestinal artery from where?
Yes.
From where? Direct from superior mesenteric? No, it's intestinal artery. From where? From where?
From the superior mesenteric artery.
Why umbilical artery? Not umbilical, not umbilical.
It's the superior mesenteric.
So how left colic here? Iliocecal. Yes, from iliocecal. So it's intestinal artery from iliocecal. Okay, I have another question. Okay, why pain in appendix? By the way, this is station from the checklist, from the checklist. Exactly the answers like discussed now. Regarding the question of appendix, سوري ماريا معلش بعد اذنك يعني، معلش انا اسف جدا بس انا معلش انا عايز اوريهم حاجه. What is the notes group؟ اضيفك من دلوقتي، الناس اللي بتبعت لي دلوقتي رسائل ضفنا على جروب الموك، ما انا قلت في الاول ابعتوا لي شنوده. لو فين جروب النوتس؟ اوكي. You remember this question؟ حد فاكر السؤال ده؟ From part A January 2021. You remember this question? 12-year-old boy present with suspected appendicitis. He gives, asking about the pain, about initially central pain shifting to the right left fossa. Asked about why central pain. I remember we answered for you, all of you, branches of intercostal nerves at the level of T10. You agree for this answer? No. Answer is sympathetic branches from the superior mesenteric will enter. Sympathetic branches from the superior mesenteric plexus will enter at the level of T10. This is the answer. معلش even you passed بارت ايه، لكن انا افتكرت كنت مجاوبه غلط، فقلت ايه استغل الفرصه في بارت بي واجاوبه لكم دلوقتي. Autonomic innervation of the appendix arises from the superior mesenteric plexus. Afferent sensory fibers from the appendix are carried on the sympathetic nerve fibers to enter the spinal cord at the level of T10. Please answer this question in exam by this way.
Okay.
Yes, I remember we changed it in September, but these people, الناس دي بقى لها سنتين معايا، مش سبتمبر بس، الناس دي بقى لها سنتين. Unlike the nerves from the autonomic nervous system that innervates the visceral pleura of the thoracic cavity, the intercostal nerves arises from the somatic. No, forget this. Okay, this is the evidence. And by the way, you should answer by this way. You will tell that the sympathetic branches from the superior, this is the cause of central pain, because of the sympathetic branches from the superior mesenteric or around superior mesenteric plexus will enter at the level of T10, which is a dermatome for the umbilicus or at the central pain, will cause the central pain. Okay? Good memory.
Okay. Who's next?
اوعى تقنعني انك انت هتناقشهم في اللجنه ديت.
لا خالص انا بسيبها لحضرتك.
لا انا اتغيرت.
دكتور منصور and دكتور رامي.
Hello.
Hello.
My voice is clear now?
Yes,
Yes,
your voice is
okay now.
Dr. Rami, you're with us?
دكتورة ماريا. Hello, دكتور صلاح.
ازيك يا مبارك.
Okay. We will start with Dr. Rami, then Dr. Mansour, and go on, okay? Can you identify the bone in each picture and articulate them?
لا مش كده على طول كده، استني دي.
بص حضرتك اللجنة دي بتاعتك.
لا حاولي try. Okay. In this station, I am trying to bring the most accurate or near picture from the exam. You will find 6 views for ulna, for tibia, and about 6 views for fibula. And you will find it will be written A, B, C, D like this way. And we'll ask you which bone match from the picture above and the picture below match the 2 bones which you can articulate together. The start of this station by this way. Then if you will pass this question, you will find all the questions are going smoothly. So
the upper the upper bone already is the tibia. So number A has a tibial tuberosity. So it's the left tibia.
wait. So يا شباب بس ركزوا معايا. So now we are talking about the first one, which is A. So A is right or left, anterior or posterior?
I think the left anterior.
No, A left posterior.
هقول لك على شيء. هقول لك على شيء.
Oh, yes.
Take this bone and put in yourself. So the view in front of you now. I'm talking about picture A, the first one on your left side. So this is anterior or posterior? No tibial tuberosity, by the way. And if you look for tibia above, this is not tibial tuberosity. This is from posterior. You agree?
Yes.
Okay. So you will put this in your leg now. You will put in your right or left. Take the malleolus down to be medially. To be medially. So where you will put the
left,
first.
left. This so we are on the left posterior surface.
Okay, this is left posterior.
Okay.
Okay, please, for our ladies, you are not orthopedic, so forget this question. You will not get it. خلاص? Because I will not take time in this question. Okay, go for picture number B. This view, anterior or posterior?
This is anterior.
Because of what?
Because of tibial tuberosity.
Okay, and put the malleolus medially. So where you will put this?
So this is left anterior.
So this left anterior. This left anterior. Then third picture.
Right posterior.
Okay, and the last one is right anterior. Come now for the fibula. Look for the sharp line in the middle. A sharp line in the middle. This will be anteriorly. The sharp line, if you will go, it's a sharp anteriorly while it will broad posteriorly. This is for the fibula. So first picture is anterior or posterior?
Posterior.
For fibula.
Anterior.
Sharp line will be anterior. The sharp line in the fibula will be anterior. So you have sharp line here. So picture A is anterior, picture B is posterior, C anterior, D posterior. تمام?
Okay.
Okay. Medial and lateral. So right and left. Both the malleolus laterally.
Right.
Right.
So
right.
one is
the number A is right.
right anterior.
Yes, right anterior.
Number B?
Right posterior.
And continue by this way, so you can articulate together. Pass this question. I can't explain more. So you will take one with other one, which will be can be articulated together. You will take right anterior from the tibia and the right anterior from the fibula together. So you will take one with other. Yalla, next.
Okay, next, Dr. Rami. These bones.
المرة الجاية مش هقولها، انت هتقولها كده.
لا حضرتك هتدخل كل مرة معايا عشان تشرح الحتة دي.
مش انت فهمتها ولا لا؟
أنا فاهماها أيوه، بس مش بعرف أشرحها طبعا. Okay, so these bones with the talus will form which joint?
Ankle joint.
Okay. Next question, can you demonstrate on yourself the movements of this joint?
Plantiflexion and dorsiflexion.
Okay. Okay, Dr. Mansour. What are the muscles responsible for these movements, plantar flexion and dorsiflexion?
For dorsiflexion is tibialis anterior, extensor hallucis longus, extensor digitorum, and pronatus tratus. For plantar flexion is gastrocnemius, popliteus, and soleus, and also extensor hallucis longus, extensor digitorum longus, and tibialis posterior.
Okay, but popliteus is not one of them.
Popliteus is not one, yes.
Okay, next question. Can you demonstrate eversion and inversion on yourself? We will skip it. Can you tell me at what joint these movements happen?
In subtalar joint, and the type is synovial plane joint.
Okay. Next question, Dr. Rami. Can you tell me the insertion of the anterior and posterior and peroneus longus and brevis. Okay.
So tibialis anterior, I think is
Yes.
the first metatarsal.
I'm sorry, the insertion, yes. The insertion of the tibialis anterior, where?
I think first metatarsal and navicular.
This is the, which one, posterior or anterior?
Anterior.
No.
And the posterior.
The tibialis
Oh,
anterior insert in the medial cuneiform and the first metatarsal. Okay. The
Okay.
tibialis posterior.
And the first metatarsal and the navicular.
Navicular and medial cuneiform.
Okay.
Okay, what about the peroneus longus?
I don't remember. Can you skip this or answer it?
Okay, the peroneus longus, we have the medial cuneiform and the first metatarsal, and the previs is the tuberosity of the fifth metatarsal.
Listen by very nice way. Peroneus muscles laterally doing eversion, so they will come from laterally. Brevis, it will be at the first metatarsal, for it, which is the fifth one. The first metatarsal for laterally, the first metatarsal you will meet laterally. It is the base of the fifth metatarsal, okay, or the tuberosity of the fifth metatarsal. This is brevis. While longus will cross to the medial cuneiform and the first metatarsal. Okay.
Okay, next question. Can you tell me the compartments of the leg, the muscle, and nerve supply of each?
So there is
you can also go because you didn't answer to the first question. Dr.
For
Rami.
me or for Dr. Rami?
Or Dr. Rami, yes.
so the compartments of leg, anterior compartment, posterior compartment, and lateral compartment. The anterior compartment nerve supply is deep peroneal nerve, lateral compartment superficial peroneal nerve, and the posterior compartment is the posterior tibial nerve.
Okay, enough. Dr. Mansour, can you tell me the muscles in each compartment?
Yes, in anterior compartment, the tibialis anterior and extensor hallucis longus and extensor digitorum longus and peroneus stratus. In lateral compartment, the peroneus longus and peroneus brevis. In posterior superficial, gastrocnemius and popliteus and soleus. And deep tibialis posterior extensor digitorum
And the
and
superficial, again, the superficial, the gastrocnemius.
Gastrocnemius soleus and plantaris.
Yes.
And plantaris. For the deep is extensor digitorum, extensor hallucis, and tibialis posterior and popliteus.
Okay. Okay, next question. Dr. Rami, can you tell me the dermatomes of the foot?
So the dorsum of the foot, the medial part is by L5, and the lateral aspect by S1.
The medial part is which part?
Medial of the dorsum is L5.
Sure.
I'm not sure.
Okay. Lateral is?
Lateral is L5 and S1.
S1, okay. So medial is L4, okay, and L5, and lateral is S1.
You can tell medial of the ankle over medial malleus L4, and the tip dorsum of the foot it will be L5 medially, while laterally S1.
Okay.
Yani, as the picture here, as you can see, the medial part is divided into two parts, L4 and L5.
تلت medial malleus خلاص يعني will not be more
تمام.
specific. Medial malleus over medial malleus L4, dorsum of the foot L5, and the remaining of the medial of the leg of the foot L5 also, while lateral aspect of the foot and the ankle it will be S1.
Okay.
Okay, that's the last question.
لا ارجعي.
I have the last question I have.
خلاص يا. اوكي.
The previous slide as well.
Okay, wait. No, we have many questions. Okay.
We have another station for the ankle. Yani there is another station.
كملي. طب حطها بعد دي. كنت كملوا حد معاك التاني يكمل اللجنه دي الاول. لا هكمل اللجنه دي لان عندي اسئله فيها.
طب ثانية واحدة أجيب لحضرتك اتنفخت.
Okay.
Okay. Dr. Rami, can you tell me the name of the tarsal bones?
Yes, number G is the calcaneus, number H is the talus, and the number A is the navicular, and the number D is the medial cuneiform, number C is the intermediate cuneiform, number B is the lateral cuneiform, and the number I is the cuboid, number E is the first metatarsal, and the phalanges are number F.
Yeah. Can you also tell me the articulations? The main articulations, yani?
The subtalar joint and the ankle joint, subtalar between the talus and the calcaneus. And the talus and the navicular, and calcaneus and the cuboid.
Okay. Next question, can you tell me the arches and the component of each?
Yes, we have three arches, medial longitudinal arch, lateral longitudinal arch, and the transverse arch. The medial longitudinal arch by the calcaneus, talus, navicular, medial cuneiform, first metatarsal, and the lateral.
Enough, and we will give a chance for Dr. Mansour to complete.
Yes, for lateral arch, the calcaneus and cuboid bone, and lateral to metatarsal bone.
This is the lateral.
Yes. You want me to finish the medial or going to the lateral?
لا خلاص خلصنا الميديال واللاترال. What else?
There is the transverse. The transverse it's 3 cuneiform and cuboid bone, and base of metatarsal bone.
Okay. Okay. Next question. What is the structures under the extensor retinaculum?
Yes, tibial is anterior. Okay. Extensor hallucis is longus. Anterior tibial nerve, anterior tibial vessel, anterior tibial nerve, and extensor digitorum longus, and peroneus tragus.
Okay, Dr. Rami, what's the structures behind the medial malleolus?
The tibialis posterior, and the flexor hallucis longus, posterior tibial vessels and the nerves, and the flexor digitorum, and peroneus.
خلاص, enough. Okay, Dr. Mansour, can you identify structure number 12?
Substanticulum tali of calcaneus bone.
Okay. Okay. Dr. Rami, can you identify the deltoid ligament?
It's number 6.
Okay. The calcaneofibular ligament?
Number 3.
Perfect. Dr. Mansour, the posterior talofibular ligament?
Posterior talofibular, number 19.
Perfect. Again, the components of the ankle joint. Dr. Mansour?
Yes, a component of ankle joint is the lateral malleolus of tibia, and lateral malleolus of fibula, and medial malleolus of tibia, and trochlea of talar bone.
Okay. Type of movement at the joint?
Plantar flexion, dorsiflexion.
At which movement is the joint more stable, Dr. Rami, and why?
During dorsiflexion, because The space is limited, or the talus is the movement of talus is limited, becomes more limited.
Dr. Mansour, you have another answer?
Yes, because the trochlea of talus bone, it's wider on anterior side and narrower in the posterior side. So it's more stable in dorsiflexion because it's in wider. So the space of the joint will be very narrow, but it will be not stable in the plantar flexion because the space will be wide in the joint.
Okay, now. Okay, can you tell me the components of the subtalar joint?
Talus bone and cancellum bone.
Dr. Rami, can you tell me the movement at this joint?
Inversion and eversion.
Can you tell me the type of this joint?
Synovial joint, synovial hinge joint.
No.
Oh, please pass this.
It's plain.
Okay.
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 Okay. Okay, last question. Can you demonstrate the pulse of the foot?
There is a posterior tibial pulses behind the medial malleolus, and the dorsalis pedis pulse, which is lateral to the extensor hallucis longus tendon.
Okay. Okay, this is the last question I have.
Back.
Dr. Salah.
You have two important stations. Will not be out of this discussion. What here, everybody? Will not be out of this discussion. Hand, extensor of the hand, and this ankle. So she covered everything. Plus, the question to identify the insertion of tibialis posterior, tibialis anterior, tibialis longus, and the brevis will ask you to demonstrate in the picture or in the in front of you. So please look for this. The tendons, look for the tendons of them in the prosection and in pictures. I didn't share it before, but they ask to identify on the prosection or in the picture in front of you. Okay, not only to mention only. This asked last time. This station came before in Bahrain, and they have actor. Okay, I don't know what will happen with you. In actor, he will ask you also to demonstrate all the movement, dorsiflexion, plantar flexion, eversion, and inversion on the actor. Demonstrate on the actor also the reflexes, ankle reflex and knee reflex. Demonstrate also on the actor the pulses. Show me what is the pulses, okay, and show me how to check the pulses. Lastly, demonstrate in the actors the dermatomes, not only foot. Ask it about all the lower limb. So C1 at the inguinal, below the inguinal ligament, C2 mid of the thigh, C3 anterior of the knee, C4 medial aspect of the leg and the ankle, C5 dorsum of the foot, and S1 lateral aspect of the foot or the sole. Okay, these are the questions asked before. Plus, the worst two things in this station. Number one, identification, and I think we make it easy. Number two, yes, this is not the question now. Not the question now, please. Not the question now. How to study anatomy. Okay. We are in life now, and we are considering a very important thing. Don't ask any question out of this. We will reply for all your questions. Okay. About the ligaments. This is not the lecture of the ligaments, and all of our candidates, they told me ligaments pictures were very bad. I get some pictures. Some told me about this picture. By the way, Dr. Maria, this is the picture about the muscle, internal oblique muscle direction. This is the picture exactly. They told me this is the picture came. Okay. About these ligaments, some told me and they sent me this picture, and they told me this is the nearest picture of the exam. Really? You can imagine? Okay. This is a picture discussed with Maria. This exactly. Thanks for دكتورة غادة كمان. I will tell her thanks every time. She sent me this picture, came in her exam, and told me this is the exact picture came in my exam. And by the way, this was the picture of the exam about appendicitis station, and this was the picture you can see here. And but يعني, you can see this picture. This is from the book, but this picture came in exam by this way. They make more zoom and they came by this way. So keep this. Okay, this is the ligaments. Some told me the ligaments, but with many colors. So if you will look for this picture and identify the ligaments, number one is number one is
I think talofibular.
Anterofibular. Two, it is the same.
The same talofibular.
Okay. Number four, down.
Calcaneofibular.
Calcaneofibular.
You can see it is between calcaneus and fibula. Okay. Number six, this is posteriorly between tibia and fibula.
Posterior tibio-talar.
You can get it by this way. Okay. And this is also another picture. You should keep these pictures. You should keep them. I think this picture is very clear also. If I will go here, number 7.
Tibiofibular.
Posterior tibiofibular.
Between tibia and the fibula, as you see. Between
Yes.
tibia and the fibula.
Posterior tibiofibular. Yes.
Number 4.
Number 4 fibulocalcaneus. لا no. Fibulotailar. Talofibular.
Between talus up and the fibula. Okay. طيب number 3.
Calcaneofibular.
Between
Calcaneofibular.
and the fibula. Keep these pictures please with you. صعبة يا ماريا صح؟
غلسة شوية.
But these are the pictures. Some told me these are the pictures that came in exam, and this is the picture in exam.
دكتور صلاح لو سمحت.
Yes.
في البيكتشر اللي هو اول واحده حطيتها انت this our first picture you put on the ankle it's not appeared if it's medial side or lateral side, so I was searching about sustanticulum tali to find it if medial, but I didn't find it. Yes, this one on the left side.
These pictures? Is this picture about ligaments only? But about
no.
About bones,
Before.
the pictures shared by Maria is
Yes.
exactly in exam. By the way, the picture shared about tarsal bone and metatarsal bones متصوره من الامتحان. خلاص scanned from the exam itself. من على الوول. من على الوول. The pictures shared by Maria. And I think I will share it in the group. I will share it in the group. All the pictures with me, which came really in exam, I will share in the group also. يلا Maria. Last station is going to take break. يلا.
Okay. Thank you guys. Thank you, Dr. Rami. Thank you, Dr. Mansour, very much.
Thank you, Dr. Maria.
Thank you, Dr. Maria. Thank you, Dr. Salah.
Thank you.
No.
Okay, next we have Dr. Farah, and I don't know, Dr. MMA, but I don't know who he is. So whoever chose this station, Dr. MMA on Telegram, can you please raise your hand or say in the group, in the comments? That's okay. So first question, the muscles of the rotator cuff, the origin insertion, we already covered it. Can you please tell me where is the acromion and where is the coracoid process?
Okay, acromion is the number 2. The coracoid is number 3. The spine is number 10.
Okay. Okay, Dr. Marwan, can you tell me the nerve related to the spiral groove and describe the nerve injury?
Yes, the right nerve, and if injured, so loss of wrist drop and finger drop, and loss of hand grip.
Why will there be a loss in the hand grip?
Because when need to more hand grip, need to more extension. for more need more wrist extension when for fine grip of the hand.
Close. Dr. Farah, do you have a comment or an answer? Why there will be loss of the...
What's the question? Loss of the hand grip?
Why there is a loss in hand grip? Okay, so when
because there is affection of the radial nerve.
So the radial nerves supply the wrist extensor, which give a mechanical advantage to power grip by synergistic activity, which cause more efficient flexion of the digits. So when there is an injury for the radial nerve, there will be a loss in the hand grip. Okay, and whenever we are talking about any nerve injury, always remember that there is a motor and a sensory. So
Yes.
in this case, which sensory?
Loss reflex.
Loss of
Loss
sense.
reflex.
Sorry. Okay.
What is the sensory loss?
Loss of sensory in the dorsum of the hand, and the lateral border of the first web space and lateral border of the forearm, and yes.
You know. Okay, Dr. Farah, can you identify the medial condyle in this nerve? In this picture, I'm sorry.
Okay, the medial condyle is number 7.
Can you tell me the nerve related?
Ulnar nerve.
Anterior or
Can you
posterior?
tell
Posterior to it. Posterior to the medial condyle.
Can you describe the nerve injury?
Sorry.
Can you describe the nerve injury?
Actually, loss of the hand muscles, the intrinsic muscles of the hand, the abduction, adduction of the fingers.
At the level of the elbow, when the ulnar nerve is affected, what will happen?
We have ulnar paradox.
Yes.
Which mean when is the injury is the level of the injury is too high, we have less flexion, less curling of the fingers.
Okay.
And vice versa.
What else? As we said, any nerve injury, we will have a sensory and a motor. You described the motor. What about the sensory?
We have sensory loss of the ulnar two fingers, 1.5. Palmar side.
We have loss of the sensation of the medial 1.5 fingers and the palmar and the dorsal aspect of the hand. Okay, next question. Dr. Marwan, hip flexors and insertion.
Iliopsoas and iliacus psoas muscle, insertion to great trochanter.
No.
Lesser trochanter.
Yes.
Next question. لا استنى، الممتحن مش هيكون فيري نايس كده زي ماريا. مش هيقول لك نو تقوم قايل له لسه يقول لك ايوه. لا الممتحن هيكون زي سوزان، ما تشوفها بكره. هيكون زي سوزان. يلا كملوا. Don't tell lesser or greater يعني don't do this mistake. يعني this is by the way very easy question. يعني okay. يلا.
Dr. Farah, can you identify the anterior superior iliac spine?
It's number 5.
Can you tell me the nerve passing medial to it?
Sorry?
The nerve passing medial to it.
Sciatic nerve.
Sciatic nerve is medial to the anterior superior iliac spine?
Oh, no, sorry.
Concentrate,
I don't
please.
know.
Dr. Marwan, do you know the answer?
Yes, lateral cutaneous nerve.
Okay, and what is the name of the condition caused by its compression?
Myalgia parasitica.
What is the root value for this nerve?
I don't know number. I don't remember.
Dr. Farah,
What's the question?
root value for lateral cutaneous nerve of the side.
I don't know.
Okay, Dr. Marwan, can you identify the pubic tubercle?
Yes, 24.
Okay. Dr. Farah, can you tell me the origin and insertion of the gluteus medius?
Sorry, I didn't prepare for this station.
Okay, Dr. Marwan, do you know the answer?
Anyone can take the place.
Between anterior and posterior gluteal line, the origin, and insertion to the greater tubercle.
Greater trochanter of the femur, the action. What is the function during walking?
Yes, during walking is abductor of the pelvis and prevent dropping of the opposite side during elevating of the leg.
Actually, it supported the pelvis when one leg is in the air, preventing the pelvis from dropping.
Yes.
Yes. Okay, what's the main flexor of the hip?
For who the question?
You can go.
Okay, the main flexor of the hip is iliopsoas and the quadriceps muscle.
And the psoas major, where is it inserted?
Psoas major.
Hmm?
To lesser
or greater?
lesser.
Okay. Origin and insertion of quadratus femoris?
Yes. Quadratus femoris from pubic tubercle, I think, to the lateral condyle of the tibia.
The origin where?
I don't know, from
Ischial tuberosity.
Yes.
And insertion?
Insertion to the lateral condyle of the tibia.
No, the intertrochanteric crest of the femur.
Okay.
Okay, this is the last question.
Quadrate loop, please. Quadrate loop. Is this the picture? Wait, please. Go back. لا الصورة لا اللي بعدها مش اللي بعدها. This is the picture I told you is scanned from exam. This is the real picture. Okay. Previous station, this was my station. When I went inside, I found the skeleton, complete skeleton, not pictures, not bones like this, complete skeleton. And the examiner started to ask me one by one. So all the questions exactly like asked for me. Okay. He will show you in the skeleton what's this, and will ask you by this way. Okay. ماريا انت ندمانه ما خدتش معايا بارت ايه؟
اكيد.
لا هو فاكر ولا حقيقي؟
اكيد طبعا.
Okay, دكتورة فرح, we are in the same situation. I know you asked me before part A to join me, but I saw the message, but I think you came when I was busy, so I didn't give you more information about our course in part A. So you will find many questions from part A, and I know you are one of the more active people in helping people in part A, by the way. And she's helping people, she has her channel, helping people in her channel. I should mention that. So اندمج طول عمرك انك ما خدتش معايا بارت ايه. حتى لما تسافر انجلترا هتندمج طول عمرك. ماشي؟ زي ما هي كده زي ما هي. Okay. So I think if you are not preparing this station, it will be very difficult for you to answer this. Anyhow, still you have time, يعني. Still you have time to improve yourself. كويس يا مروان. Excellent.
Yes, thank you. Thank you.
Okay, and next station we have Dr. Manam
يا
and
ابني
Dr. Abdurrahman.
يعني انت كاتب في الكومنت قدامها دي اللي سرق النوتس، ده انت يا زكي مفتري. انت ورايا يا ابني، لا سرق النوتس ايه؟ طب ارد عليه اقول له ده ماريا بالله عليك.
مش عارفة بصراحة.
يعني عشان البنت حتى، ده بلدياتنا يا ابني من العراق، يا ابني هتودينا في داهيه يا ابني. يلا كملوا. لا not فرح. By the way, she has the bullets and when she shared in the group she not contacted her and she told no I don't know والله really and she removed it, but really she is sharing all free materials only from us from any courses only that. مش سرقه. وبعدين ما تكتبهاش كده سرقه، قول مقتبسه زي ما هشام وجيه بيقول انا مقتبس مش سارق، تقول كده. يلا.
Okay, we have Dr. Abdurrahman and Dr. Manam.
لا بريك يا ماريا، لا اللجنه دي مهمه، بريك. لا انت بتهزري، خلينا نشرب حاجه ناكل حاجه يلا.
طيب 5 minutes break.
خليهم 10 minutes معلش. 9 هيبقى 10 والستارت 10 كي اس اي 10 بي ام كي اس اي.
دكتور صلاح. Okay, we'll start.
يلا.
Okay. First question, can you please demonstrate the pyloric plane on a subject?
For whom the question?
For you.
Pyloric? Number
Plane.
one. Pyloric plane?
Yes. Demonstrate the pyloric
this is
plane.
this is the L1 level of L1. Midway between the xephosternum and the upper part of the pubic tubercle, midway.
Okay. Next question, is this cut section from down upper or the opposite? Dr. Abdurrahman?
Yes.
This cut section from down upward or the opposite?
From down to upward.
Okay. Dr. Widad, can you identify structure number 12?
Why from down?
Because at the level of L1.
No, why? Because liver.
Liver from the left side.
Liver on left side.
Okay.
Okay, can you identify structure number 12?
Body of the stomach.
Okay, what about structure number 1, Dr. Abdurrahman?
And number 1 is, I think, pyloric antrum.
Yes. Structure number 5?
Liver.
Structure number 21?
21. Yes, the left kidney.
Okay. The space between the abdominal wall and the liver?
Subhepatic, subphrenic space.
Okay. And the space behind the stomach?
Lesser sac.
Okay. Can you, Dr. Abdurrahman, can you locate the gallbladder on a subject?
You mean I will tell the surface anatomy?
Yes.
It will be tip of the non-costal cartilage and lateral to the rectus abdominis مثلا ولا linus seminaris.
Okay, so it's the angle between the ninth costal cartilage and the lateral margin of the rectus sheath. Okay. Okay, moving down your finger and with the costal cartilage till the anterior mid-axillary line, what's the organ underneath?
Liver.
Okay. If stabbed in the epigastric region, from inferior to superior, what is the structures at risk of injury?
Most probably liver and stomach.
Which part of the liver?
left loop.
Left loop of the liver, stomach, and later on the diaphragm.
Yeah, yes.
Okay, what is the boundaries of the quadrate loop? Boundaries of the quadrate loop.
Quadrate loop from the right gallbladder laterally, from behind porta hepatis, from the medial side ligamentum teres, and from in front the bare area of the stomach, of the liver.
Okay, Dr. Abdulrahman, the boundaries of the caudate lobe.
Boundaries of caudate loop. Caudate loop lateral to inferior hepatic artery, superior portal triad, lateral fissure of ligamentum, medial fissure of ligamentum venosum.
Again, please, Mash. Again.
Superior portal triad.
The superior, the bare area of the liver. Inferior.
Inferior, the duodenum.
The caudate loop.
The caudate loop.
Caudate loop of the liver.
The inferior gallbladder on duodenum.
Inferior is the porta hepatis, and superior is the bare area of the liver. To the right.
Right to the fissure, ligamentum venosum.
No, to the right is the inferior vena cava, and to the left is the ductus venosum.
Ligamentum venosum, yes.
The left is the ductus venosum, not the right. The right is the RVC.
Hepatic part. Yes.
What is the structure separates the right and the left loop of the liver?
Ligamentum teres.
Okay. This is anterior or posterior?
Anterior.
No. What's anterior?
Anterior falciform ligament.
Yes. Anterior falciform ligament and ligamentum teres is posterior.
Yes.
Okay. In this picture, can you identify structure number 21?
Number 21. Bare area of the liver.
No.
Sorry. The caudate loop of the liver.
This is the quadrate loop of the liver, yes?
Yes.
Okay, number 2. Dr. Abidet?
Caudate loop, number 2.
Okay, number 17.
17. What is? I didn't see.
I am pointing at it here.
Falciform ligament.
Ligamentum teres.
Ligamentum teres?
Yes. Ligamentum teres. Number 13.
13, inferior vena cava.
Okay, number 20.
Portal triad.
Yes.
Portal vein.
Portal vein.
Portal vein.
Number 11.
Number 11, hepatic artery.
Yes. And number 5, it's not very clear.
I think.
Hepatic artery ودي portal vein ده common bile duct.
Hepatic duct.
Hepatic, no. Yes.
Okay, can you identify the falciform ligament in this picture? Dr. Abdulrahman?
Yes.
The falciform ligament?
Number 2.
Okay, Dr. Widad, what does it connect to?
Connect anterior the anterior liver to the diaphragm, anterior to the diaphragm.
Yes, the diaphragm and the anterior abdominal wall. What is the خلاص. What is the attachment of the diaphragm? The bony attachment of the diaphragm in particular.
Yes. معلش تاني سألتني سؤال
The bony attachment of the diaphragm.
أنا معلش قول
I think you have a problem with your internet. Well, it's my internet.
No, I'm in the duty. I'm in the hospital. I think my post is low. So this is bus. I don't know.
Okay, Dr. Vida, do you know?
Yes, right cross of diaphragm attached to the L1, L2, and L3. Left cross to L1 and L2. And medial arcuate ligament between the two crura of the diaphragm, and medial arcuate ligament medial extend from the L2 body of the L2 till the transverse process of L1 till the transverse process of L2.
Okay. So the bony attachment of the he's asking in general, so that would be the xiphoid process at the sternum, the inner surface of the lower 6 costal cartilage, and L1, 2, 3.
Thank you.
Okay, that's the last question. Thank you. دكتور سارة.
دكتورة وداد اخبارك عامله ايه؟
الحمد لله تسلم دكتور سارة.
شدوا شويه.
ان شاء الله. شد على الله.
I will give some advice for Sudanese in Arabic. يعني this is specific for Sudanese. السودانيين ما عندهمش border line او معنى ما عندهمش وسط. السودانيين ما عندهمش وسط. يا بينجحهم بسكورات عاليه يا بيفضلوا فيها. ما اعرفش. عندكم مشكله. انتوا عندكم مشكله ومش بتكلم، انا بتكلم عليكم بالذات لسبب. I started studying Mrcs by helping of Sudanese, and they have much respect from me to them. So what I discovered before I'm giving courses, Sudanese only they are passing this exam because they have they have records, and they are helping themselves. Till I joined their groups and I started to publish records and they started to give courses. Now all people all over the world they are passing, except the Sudanese. I don't know, they stuck. So take it serious. Take it serious. Just if you will follow these mocks, you will pass. It's very simple. 2 or 3 hours study, tomorrow 2 or 3 hours, pass anatomy. It's very simple. هنقعد بقى نتدلع. مش مشكله النهارده، هتيجي بكره مش هتخلص. اوكي. In Dubai exam, I think Dubai last June, they asked what is the structure passing in the central tendon. Answer.
دكتورة وداد.
inferior vena cava.
And what? And right phrenic.
Right phrenic nerve.
The question asked by this way suddenly. And it's the same station, but asked by this way suddenly. So what is the structure passing in the central tendon, IVC, and right phrenic? Inside which part of the peritoneum the proper hepatic pass or run? I think this question discussed with Dr. Maria. What is the answer?
Lesser augmental.
Yes. A stab wound in epigastric, which two organs will be injured. Mention two only.
What? Cannot hear Dr. Salah.
Stab wound in the epigastric.
Stomach and liver.
Stomach and liver. Left lobe of the liver.
Yes, left lobe and stomach. Where left lobe can be extended? Till where?
Till the body of the stomach.
Left lobe. Where?
Till the body of the stomach.
No, till the mid axillary line.
Where? Not left.
Right.
Left.
Left clavicular.
Fifth space mid clavicular line in the left side.
Yes.
Okay. Left. This question asked for me, by the way. This question asked for me. By the way, حد الصورة اللي قبلها يا ماريا كده؟ في صورة قبلها. اللي قبلها كمان. Quadrate and quadrate loop. Maria, by the way, this station discussed in the posting, by the way. And if you want it written, go for the group, you will find it, this station. The two pictures. The first one came in UK and came in Cairo. Okay. But you have some updates. The picture on your right hand, it is the same station, came by this way. So please keep identification in the first picture on your left hand and on the right hand also. Keep these two identification because these two pictures came before. First one came before and then other one. Okay. I think we covered all the questions here. I have nothing to be added. Yalla, Maria.
Thank you, Dr. Thank you, Dr. Abdurrahman. Next station is going to be Dr. Hiba and Dr. Yasmin. Dr. Yasmin. Dr. Yasmin, can you please raise your hands?
يا هبه عايزين نخلص لازم اسجلها لك عشان لما تاخد كورسات عشان قوليها عشان لما تيجي تدي كورسات يبقى انت كده مسجل عليك ماشي قول اوكي
يا لازم اخلص
ان شاء الله. Okay, this station by the way came last time recently RCSI Edinburgh Ireland on البحرين exam 27th of last November and this is why my station also on البحرين and when I discussed with Subih all the questions exactly like came for me in my exam. So no more updates except what we will add today. One of the most important stations plus ankle. And if you will keep this in ankle, most of exams they have ankle. And so if you will go for the exam and the first day you have ankle station. So for sure next day maybe hand. Yeah.
Okay. We will start with you, Dr. Hiba. Can you please name the carpal bones by numbers?
Okay. From proximal to distal and from lateral to medial. Number 3, it's pisiform. 2 triquetrum. Number 1, it will be lunate. And
2 is what?
Unite.
Yes, 2 is lunate. Number 1 is?
Number 1 is scaphoid.
Okay, number 4?
Number 4 is trapezium. 5 trapezoid. 6 cavitate and 7 hamate and hook of the hamate.
Okay, good. Okay, Dr. Yasmin, can you identify in this picture the median nerve?
Median nerve 7. Median 30 medial
لا sorry not ulnar nerve. Okay, medial nerve.
Rahiba?
Median is 21.
Yes.
21 median.
Okay,
Where?
Dr. Yasmin. Flexor retinaculum number?
The 90.
Okay. Ulnar artery number?
Ulnar artery 38. 31.
31, yes. Okay, superficial palmar arch?
22.
29.
29, yes. Okay. Okay, Dr. Hiba, can you tell me the structures passing through the carpal tunnel?
We have the median nerve, the four flexor digitorum profundus, four tendon of flexor digitorum superficialis, one tendon of flexor carpi-radialis, and one flexor pollicis longus.
Okay, perfect. Dr. Yasmin, can you tell me some movements and the muscle and nerve supply responsible for these movements?
Flexor carpi-radialis not passing through.
I'm sorry?
Flexor carpi-radialis, I think, not passing through the carpal tunnel.
Flexor.
Only flexor retinaculum.
It's passing through, yes. Can you tell me the thumb movements, muscles and nerve supply for each?
Movement, abduction, adduction, that.
Each movement, what is the muscle supply for it and what is the nerve supply of this muscle?
هني هارشس هني abductor harassas longus, abduction, and muscle supply at ulnar nerve. Flexor.
What is the movement?
Abduction.
Adduction. Okay, what's the muscle?
Adduction, adductor harassas longus.
Adductor pollicis.
Sorry. Abductor pollicis.
Okay. What's the nerve?
Nerve, ulnar nerve.
Okay, next movement.
Flexor carpi.
What's the movement?
Okay, flexion.
Okay, so say it's flexion. بتدخلي ليه في الفلكسور كارباي على طول? Say that it's flexion. Okay, flexion. Which muscles?
Flexor carpi-radialis.
Are you sure?
Sorry, flexor pollicis brevis and longus.
Okay, supplied by what?
Radial nerve.
Okay,
The brevis nerve.
The flexor pollicis longus supplied by the interior interosseous and the flexor pollicis brevis by the recurrent branch. Okay, next movement.
Abduction. Abductor pollicis longus. And brevis.
And what's the nerve supply? The examiner is not going to tell you this.
Radial nerve.
Which one supplied by the radial nerve?
The abductor pollicis longus. Skip.
What about the abductor pollicis brevis supplied by which nerve?
Median nerve.
Median nerve. Okay, other movements?
Position.
Okay. The muscles.
I forget. I didn't review.
The opponent's pollicis, the flexor pollicis brevis, abductor pollicis brevis, all by the median recurrent branch. Then we have extension by the extensor pollicis longus and brevis by the radial nerve. And we have radial abduction or radial extension by the abductor pollicis longus and brevis by the radial nerve. Okay, Dr. Hiba, how can you check for the flexor digitorum superficialis and profundus function?
Okay, for the flexor digitorum profundus, I will fix the middle interphalanx. I will fix it by my other hand, and to flex the distal one, the distal phalanx for each finger. And
Okay.
for the flexor digitorum superficialis, I will support the other fingers in the extension position and flex the one I'm not supported in the proximal phalanx.
Okay. Dr. Yasmin, tenderness at the anatomical snuff box, and the following X-ray was the result. What is your diagnosis?
Avoid.
Okay. Dr. Heba, what's the common complication?
Avascular necrosis.
To which part?
The proximal part.
Why?
Because it receives its blood supply from the distal.
Okay, Dr. Yasmin, can you identify structure number 2 on this picture?
Number 2. Okay, يعني coronate process.
Lister tubercle.
Yes, Lister tubercle. What is the significance?
Can I say
yes,
the tendon of extensor pollicis longus, it will wrap around it, the medial side.
Okay, so it acts as or serves as a bully for the tendon of the extensor pollicis longus, which wrap around it. Okay. Next question. Dr. Yasmin, what's the attachment of the flexor retinaculum?
I forgot.
Dr. Hida, do you know?
From proximal, from medial to lateral, the tubercle of the scaphoid to the pisiform, and distally, the hook of the hamate to the trapezium.
Okay. Can you tell me the median nerve sensory distribution in the hand?
2/3 of the lateral part of the palmar surface. Dual finger to 3.5 finger, and tips of the finger.
Okay. Okay, can you, how do you test for the ulnar artery, or what is Allen's test?
Allen's test, the compression, elevate the hand and compression in the both radial and ulnar side, 7 seconds, and the decompression, and will check the flow. For EBG test.
For what?
For check for EBG testing ulnar flow.
So you elevate the hand of the patient and ask him to make a fist for 30 seconds.
Again,
Then you
and
apply pressure for both the
and
ulnar and the radial to occlude both. And while the hand is still elevated, as soon as it becomes blanched, release pressure on one of the arteries and see if the color is returned in 7 seconds. Nothing about ABG here, I think.
okay, I think the test for okay.
Dr. Heba, can you identify structure number 9 in the picture?
Extensor digitorum.
Number 10. Dr. Yasmin.
Number 1.
Number 10.
10.
What is the structure?
And this is
extensor
okay.
indicius. Structure number 13.
Extensor retinaculum.
Okay, structure number 12.
Extensor pollicis longus.
11.
And previous, extensor pollicis previous.
Okay. 5.
Extensor carbarradialis longus.
6.
Sorry, previous, and 6 longus.
Yes. Okay, where is the insertion of structure number 9?
And the extensor expansion, the extensor, yeah.
Yes, the extensor expansion or the extensor hood.
Yeah.
Okay, last question. What is extensor hood? Dr. Yasmin?
By this station.
Okay, Dr. Heba, do you know what is the extensor hood?
It's a fibrous expansion from the extensor retinaculum. I think so. I can't recall it very well.
The translucent fibrous expansion on the dorsum of the proximal phalanx of each digit.
Yeah.
Where the
Yeah.
insertion of the extensor digitorum tendons happen. Okay, this is the last question I have.
ارجع لي كده يا ماريا، ارجع لي كده. ازيك يا ياسمين؟
أهلين.
كنت عايز اشوف اخبارك من الدسكشن. طيب اقول لك ايه؟ لازم مكالمه، لازم زعيق، لازم نتخانق بقى سوا. باي ذا واي دكتوره ماريا، Yasmin joined us in part A only 2 months, only less than 2 months, and she scored around 86. كان 86 يا ياسمين.
88.
88. طيب ذاكرتي باظت. In 2 months in part A 88. And now you have more than one or 2 years and you're not studying. عارفين المشكلة ايه؟ The problem for people who has 1 or 2 years، الكلام ده معاكي برضو يا هبة انت وداد. These people who stayed for long time وبهاء طبعا. You forget everything. You forget how to study.
Yes.
You will suffer by this way. You have 1 month practice. الكلام ده على فكرة الناس القديمة معايا كلنا عارف الموضوع ده، وبيبقى صعب جدا انه يرجع. You should do more efforts. Okay, I know these people, Dr. Maria, they are amazing. يعني I know وداد and I know بهاء. I know also دكتورة ياسمين. عارف ياسمين كويس جدا يعني. أنا فوجئت. يعني I'm waiting. I know Yasmin, she will do great. But by this way, it's very difficult. طيب maybe the station also is difficult. يعني أنا مش عايز أضغط عليكم وأقول عليكم كلام كتير وأصعب عليكم. But I know this station is difficult also. This station is difficult also, especially for non-orthopedic. Especially for non-orthopedic. But I know Yasmin, she can manage anything. يعني دي من ليبيا. الليبية. بص يا ماريا، يعني I can tell you from my experience about nationalities, especially about nationality. Libyan, Iraq, and Yemen. معلش بقى تحاسب الأردن ومصر والسودان. دول عايز يتولع فيهم كلهم. خلوكم على جنب. ما حدش يزعل من دي الحقيقة. Egyptian, Jordan, and by the way, يعني for Asian, they are doing great. Even when I went for hands-on in Bangladesh, they are doing great by the way. So they are studying well and they can manage their situation إن شاء الله يعني. But I'm talking about Arabs. يعني really بص يا ياسمين، يعني ان اللي بيجي لي من ليبيا مستوى عالي جدا، وانت كنت مستواك عالي فانت لازم تشتغل. والعراق برضه نفس القصه، واليمن طبعا. اليمن ديت العراق ده الاول على الكل. هو محمد فاضل موجود؟ فاضل موجود ولا مش موجود؟ طيب محمد فاضل is here I think. He has scored in the Royal College and Hassan al-Salahi in the next exam also from Yemen. Both of them highest score in the Royal College. طيب المصريين خليهم على جنب بقى، انا مش عايز اتكلم، انا جنب. محمد فاضل موجود اهو. المصريين خليكم على جنب، مش عايز اتكلم يعني. عندكم 500 حاجه، عندي دوام، عندي ديوتيز، مش فاضي اخد اوف، بحضر دكتوراه. طب معلش، طب ظروفي 500 شغلانه. والله ما بتكلمش، بس يعني you should make more efforts. You should make more efforts. Okay. This is station. Okay. This is station as discussed now with Dr. Maria. I have some people they sent for me in the hand asking mainly about the dorsal of the hand. Agree. ما اعتقدش يا منى حطيت السؤال ده. The first dorsal interossei. دكتورة هبة.
Yes.
We'll ask you to identify first dorsal interosseous muscle. Tell me origin, insertion, nerve supply, action.
والله كتير صراحة.
طب nerve supply. لا listen. In this situation, you don't know the answer. So try to get only 1 mark. What is the nerve supply of the dorsal interosseous?
Radial nerve.
باب. dorsal interossei, palmar interossei.
Yeah. The ulnar nerve.
Which branch of ulnar nerve? خلينا بقى نشحت الإجابة. Which branch?
Anterior deep ulnar nerve.
Deep ulnar nerve. Okay. We'll ask you to identify the muscle. I shared one picture for it. Origin, insertion, and action. What is the action of this muscle? If origin and insertion will help you to identify the action. This muscle first the dorsal interosseous will come between thumb and the index finger. Thumb and the index finger. So it will come from the first and the second metacarpal bones, and then will be inserted into distally in the second pharynx. Yani first and the second metacarpal, then above the metacarpal is the pharynx. So it will come above. So if we're coming from thumb to index finger, what is the movement?
Adduction. Adduction to.
Will abduct the fingers away from the thumb, which are do contraction. Will abduct others from the thumb. So will abduct index, middle, or ring fingers. Okay. And also rotation of the index. Rotation of the index. Okay. And can assist in thumb adduction. Can assist in thumb adduction. By the way, thumb adduction by which muscle? Thumb adduction by which muscle?
Adductor pollicis.
Longus or brevis?
Adductor pollicis longus.
Yes. Longus or brevis. It's not adductor pollicis.
Pollicis.
Okay. By which nerve adductor pollicis?
The median ulnar nerve.
Ulnar nerve. Yes, excellent. So go for next picture, Dr. Maria. I think Maria asked you all the questions. The one who sent for me, he told me they asked also about extensor carpi ulnaris. Which one? Extensor carpi ulnaris, Dr. Maria? Okay, number 6.
أعتقد
This is ulnaris in the opposite side. 7.
تهيألي 7.
7. It's a 7. Ask it about it. By the way, this is the picture coming exam. Okay. Ask it to identify it. Flexor pollicis longus and the flexor pollicis brevis. It will be in the opposite side.
Flexor pollicis. Flexor دي ده مش هتبان هنا يا دكتور.
I think extensor.
Extensor دي extensor ده longest ودي brevis.
Yes.
How to know them?
12 and 11.
Number 11 is less than 12. So 11 will be brevis. By very simple. And by the way, brevis in the first compartment. Okay. And the 6 is radialis. 6 is radialis. By this way, 11 and 12. Okay. 11 will be more away. Then we'll go for extensor digitorum and indicis. Numbers of digitorum and indicis.
Digitorum 9. And this is 8. Or
what is 8?
ايه دوت 8 هنا هوت indicis.
No, not digit minimi. Extensor
الانديشس 10.
10. Indices and the digitorum will supply the index finger, will bring from the index finger from above, will bring from above. So indices is in or medially. So the tendon which near from the little finger will be medially, and the tendon near from the thumb will be laterally. Indices in, so indices is medially. So 10 is indices, 9 is digitorum. Okay. Everything about extensor hold very important. Everything about extensor hold. I think you asked all the questions, Dr. Maria, for extensor hold or not?
What is extensor hood? What is the site of an insertion? That's it. I don't know any other questions.
Okay. This question asked in UK, how tendons can keep in its position with contraction because of extensor expansion mainly extensor hold. What is extensor hold? This is fibrous expansion on the dorsum of proximal phalanx of each digit. Okay, triangular with base proximally. Okay. What else in this station? Anatomical snap box. Boundaries of anatomical snap box asked also in Bahrain. This class in Bahrain exam. What is the boundaries of anatomical snap box?
Posterior medially extensor pollicis longis. Anterior lateral extensor pollicis brevis, abductor pollicis longus.
Excellent. If you have tenderness in anatomical snap box, indicate what?
Scaphoid fracture.
What is the most complications that can be happened with scaphoid fracture according to its blood supply?
Avascular necrosis.
Why?
Because it receives the blood supply from distal to proximal.
So which ball will be more affected, the proximal part after fracture? The proximal or distal part will be more affected?
Proximal.
Which ball will be more affected, proximal or distal part?
Proximal.
Proximal. Because distally taking blood supply distally, so distal already get its blood supply. Okay, what else here in this station? What is the root value of intrinsic muscle of the hand?
Intrinsic muscle of the hand. C8 T1 T1 yeah.
T1. This asked for me also in this station. في حاجة تانية يا ماريا؟
أعتقد تمام كده.
لا لسه افتكرت لما قالت لي اعملي الانتست على ايد انا الايرلنديه. ايه الحتات دي؟ اصعب فيها يعني. Okay. I have Irish examiner. She's very young by the way and she's حلوه يا شباب. يعني اقول لكم ايه، كانت حلوه يعني ايرلنديه يعني مش مصريه. طيب المهم she asked to do an test in herself. Okay. And asked me movement of the thumb. Movement of the thumb, very important. To do movement of the thumb, muscle responsible for this movement. بص يا بهاء، انا عارفك انك ملتزم، هتجي لك تقول لك امسك ايدي واعمل الان تيست، اعمل بعد كده بروح اعمل عمره. معلش يا بهاء، علم يا اخي، علم يعني هنعمل ايه؟ المهم so movement of the thumb very important to do. اقول لك تيجي بس يعني خلاص. طيب movement of the thumb, you should know the movement of the thumb muscle for every movement plus nerve supply. In my exam, she asked me to do only thumb movement. Okay, but when I finish my exam, in next exams, the update for this station asked about the nerves related, like the flexion of the thumb by flexor brachus longus and brevis, and this will be by medial. The longus from anterior interosseous, while flexor brachus brevis, one of the loop muscles, by recurrent branch of medial nerve. Again, the flexion of the thumb by flexor brachus longus and brevis. Flexor brachus brevis is from the muscle, so direct from medial nerve recurrent branch, while longus from anterior interosseous. Extension brachus longus and brevis, both by posterior interosseous nerve branch of radial nerve. Abduction. Abductor brachus longus and brevis. Brachus longus by radial nerve. While abductor brachus brevis, this is one of the root muscle also, recurrent branch of medial nerve. Adduction, this is by adductor brachus longus or brevis, and this is by deep branch of medial nerve. Opposition by the medial nerve, one of the roof muscle, recurrent branch of medial nerve. Brachus, flexor brachus brevis, and so on. Okay. Asked to do this movement, I shared the video. I did it in YouTube before. To do this muscles, to do the movement with muscles and the nerves. This is a station. This is a station.
Long
Hand
station.
and ankle finished. If you keep this, for sure 100% you can get the full mark in this station. يلا. معلش يا مريم، انا طولت بس دي مهمه، معلش انا اسف.
لا لا اتفضل. خلاص العيد راح. اوكي.
ما تحسنيش بالذنب، ما تحسنيش بالذنب.
Okay, next we have Dr. Mona and Dr. Nabila.
Hi.
Hello.
هاي صوت واصل صح؟
Yes, I can hear you very well. Okay.
معلش يا جماعة تسمعوا كلام إجابات تتعب يعني بس مش مشكلة.
Dr. Said, you're next. Okay, first question, Dr. Mona, can you please identify the aorta, the vertebral level, and the surface marking?
اوكي ممكن هو يبتدي الأول، ما بحبش السؤال ده سوري.
Okay, Dr. Nabila. Dr. Nabila, are you here?
Yes, I can hear you.
Can you please identify the aorta, the vertebral level, and the surface marking?
Yes, the aorta extends from T12 to L4, and the T12 is about 4 centimeter above the transpyloric plane in the midline, and the L4 is about 2 centimeter left from the midline over the supracrystal line.
Okay. Okay, next question. Can you identify the branches supplying the GIT?
Celiac, inferior-mesenteric artery, inferior-mesenteric artery.
Okay. Next question. The posterior branches of the aorta?
The posterior branches are the vertebral arteries and the median sacral artery.
Yes, the lumbar branches and the median sacral arteries. Okay. Next question. The IVC tributaries?
Common iliac. And I'm not quite sure, like celiac, sorry, splanchnic vein. No, I'm not quite sure, to be honest.
Okay.
Common iliac veins.
Iliac, yes.
Common iliac veins, the renal veins, the right conoidal, the right suprarenal, and infraphrenic, and hepatic veins.
Okay. Next question. The structures passing in front of the aorta?
Celiac trunk, superior-mesenteric artery, body of pancreas, and third part of the duodenum, I guess. I think splenic vein, renal vein, left renal vein, right? Yes.
And the root of mesentery at last.
Oh, okay, sorry.
Okay, aortic this is an aortic angiography. Can you please identify the branches?
Yes, the A is abdominal aorta, and B and C are the right and left common iliac arteries, and D is the left renal artery, and E is the supramesenteric artery. F is the left.
E is what?
Is renal,
right renal artery. Sorry.
Yes.
Okay. F is the left gastric.
F is what?
Splenic artery.
Is the splenic artery, yes.
Splenic artery. J is the common hepatic. J is the left hepatic, and K is the right hepatic, and I is the gastroduodenal artery.
Okay.
And H is the inframesenteric artery.
L is the inferior mesenteric.
L is the inferior artery, yes.
Okay. Can you identify the pathology in this picture?
There's aortic aneurysms, like aneurysm.
Where?
It's abdominal aneurysm.
Where?
Infrarenal.
Yes. Infrarenal, saccular, aortic aneurysm.
Aneurysm. Yes. Sorry. Yeah.
Okay. Can you define aneurysm?
Yes.
Dr. Nabila?
Yes. It's an abnormal localized dilatation of the vessels more than 1.5 times than its normal diameter.
Okay. Can you tell me the risk factors?
The risk factors are the hypertension, due to atherosclerosis, diabetes mellitus, hyperlipidemia, and some infections like syphilis, and there's some congenital. These are the yes, these are the risk factors. And
Congenital like what?
Congenital Marfan syndrome, and it can be traumatic also.
Yes. So you have acquired as in cases of atherosclerosis and atherosis, congenital as Marfan and Ehlers-Danlos, and infection as in syphilis, and trauma like false aneurysm. Can you define dissecting aortic aneurysm?
Me? Or it is it's like separation in the arterial wall, and it could be extended proximally or distally. Okay.
Yes. That's the last question. Thank you for both of you. Dr. Salah, your comments.
Okay, Dr. Maria. Sorry, Dr.
معلش
Nabila.
Dr. Salah. Dr. Said, the aorta 3 centimeter, that is true, but the definition is more than 1.5 its original diameter, 1.5 times, not 1.5 centimeter. Okay, so whatever the original diameter of the aorta is going to be 1.5 times its original diameter, which is usually more than 3 centimeter in the aorta. So it both is correct.
First, I'm so sorry for our friends in Bangladesh and Malaysia, India, because it's very late. Dr. Nabila, what is the time now? She slept. Dr. Nabila. She's muted, Maria. طيب. دكتورة منى, listen.
I'm sorry. أنا عارفة إن أنا يعني زفت، بس
لا
أنا فعلا يعني.
لا اسمع بس اسمع.
It's 2 a.m. in Bangladesh.
I know. So I'm so sorry for that. I know. I stayed in Bangladesh for 3 days, I think. Okay, and I know the time difference. How is hands on? Is it make difference for you?
كلام لمين مش فاهمة.
هي ما كلها عندهم في بنعمل هاند اون بس. Okay. First, you will be panic in exam like now. This is the benefits of this discussion, to get one station and start to discuss with us. You will be panic like this in exam. So better to be quiet and start. If you don't know the answer, tell him pass. It's a very simple. It's very simple. Okay. But if you start to be panic, you will miss many questions, and the examiner will recognize that, and you have some marks for professionalism. You will miss it. Okay. Okay. Regarding with this station, I think Dr. Maria, she covered everything. This station, one of the most amazing station. It will go by this way. The definition of aneurysm should be by this way. Abnormal, not like in our book, is an abnormal localized dilatation of a blood vessel to more than 1.5 of its normal diameter. Only that. Classification of aorta of aneurysm. Asked what is the causes or what is the classification, what is the cause of classification, or what is the types. You will tell according to the cause: acquired, traumatic, inflammatory, infective, congenital, like discussed with Maria now. So nothing to be added except definition of aneurysm and the cause of aneurysm. Okay. يلا نركز ستيشن دكتور ماريا. احنا خلصنا ماريا، فاضل لنا كام لجنه ولا 2؟ طب ما كويس يا ماريا، هم احنا ماشيين كويس، زعلانه ليه؟
لا مش زعلانه. Okay, next we have Dr. Sayed and Dr. Sondus or Dr. Ashti.
Hello.
Hello, Dr. Sayed, how are you?
My name is
Said or Sayed?
Said, yeah.
Sayed, how are you?
I'm fine.
Okay, Dr. Sondus.
We have remaining 2 stations. يلا.
Okay.
Okay, I'm with you.
We will start first question with Dr. Said, then second question with Dr. Sondus, if that's okay.
Yeah.
First question is actually identification, so each number for each one of you. Okay. First identification, the vastus lateralis number.
28.
Okay, Dr. Sondus, the tensor fasciolata is number.
26.
Okay. The iliotibial tract.
Yeah, its continuation is 12.
Okay. The rectus femoris.
Me?
17.
Yes. The sartorius.
19.
Okay. Femoral artery.
Is 6.
Okay. Femoral vein.
10.
8.
Oh,
Okay.
8.
It's
Excuse
8.
me. Yeah, excuse me. Yeah.
Femoral nerve.
7.
Perfect. Okay. Boundaries of the femoral canal.
Me?
Yes.
Yes, medially lacunar ligament, anterior inguinal ligament, posterior pectineal ligament, and then medially femoral vein. Yeah.
Laterally femoral vein.
Yeah.
Lateral is the femoral vein.
Yes, lateral femoral vein. Yeah.
Okay. Next question, Dr. Sanders. The structures in the femoral sheath.
Femoral artery, femoral vein, lymph node.
Okay.
Deep and superficial inguinal lymph node.
Okay. Next question, the action of the rectus femoris muscle.
As a part of quadriceps, it causes extension of the knee and deflection of the hip.
Okay, next question, what are the muscles attached to the iliotibial tract?
It is 2 muscles, gluteal tensor fascial lata and gluteal maximum.
Gluteus maximus.
Gluteal maximum.
Okay, what is the function on the knee joint?
In function of the knee joint, it is attached laterally, so it causes stability during walking and running, gives stability to the joint.
Yes, it gives stabilization in extension and partial flexion.
Yes.
Okay, in case of injury of the common peroneal nerve, which compartment is usually affected?
Anterior and lateral compartment.
Okay, and sorry. And what is the sensory part affected?
Is lateral compartment and dorsal of foot.
Okay. Last question, the femoral triangle boundaries.
Femoral triangle boundaries, it started by femoral triangle. Yes. It is superiorly, it is attached to inguinal ligament, and medially it was laterally vastus medialis, and lateral and medially, and no, I don't remember. Both.
Okay, superior is inguinal ligament. Lateral is sartorius. Medial is adductor longus. Floor is
Dr. Mangus, yes.
Okay. I think this is the last question I have. So. Okay.
عايز الصورة تاني كده بريه الصورة تانية
صورة حاضر.
I want to back of the side. اوكي طيب نكمل نشوف الاول كده استنى. اوكي I think femoral triangle boundaries. Okay, identify femoral vein. Okay, identify 2 structures other than the vein in the femoral sheath.
Is the femoral artery and vein and lymph node.
Lymph nodes and nerve.
Deep and superficial inguinal lymph node.
Wait, lymph node and nerve?
Yes.
No, there is no nerve. There is no nerve. Vein and artery.
Nerve to.
The question again. Identify another 2 structures other than the vein in the femoral sheath.
Okay, is the lateral cutaneous nerve?
Lateral cutaneous nerve, yes.
Why? Artery and lymph node.
Artery and lymph node and the lateral cutaneous nerve.
Lateral artery and lymph node only that.
Okay.
Okay. What is the name of the I think they will ask you in the back to identify the biceps femoris muscle. Biceps femoris muscle. Okay. What is the name of the heads of biceps femoris?
Is medial and lateral bicep.
لا انت طلعت لي لا. Ask it about the name of the heads of the biceps femoris.
Short and long head.
Short and long head.
Long head of yes.
Short and long head. Nerve supply.
Long
supply.
nerve supply بالفemoral. No nerve.
Back. This is the hamstring muscles.
In the back, it is sciatic.
One from branch of sciatic and one from other branch.
It's the tibia and common peroneal.
Yes.
No.
Short from where?
Short is common peroneal.
Short common peroneal and long. This asked this new question and long from tibia. Okay. We'll ask also about
branches of boundaries of popliteal you mean? Yes.
لا واحدة كده. سألتك على البايسبس فيمورس. Identify the two heads and the name of these two heads. Short and long head. Nerve supply for both. And identify two structure other than the vein in the. This is updated question.
Artery and the lymph node. Yes, I remember this question. Yes.
Okay. What are the names of the two heads of biceps nerve supply? If patient got injury and torn his hamstring, what will be the result? So asking about the hamstring muscles.
Loss of hamstring muscles. Loss of
all.
Loss of extension of hip.
What is the name? What is the name of the hamstring muscles?
It's biceps, femoris, biceps, semitendinosus, and
semimembranosus.
What is the action of semitendinosus and semimembranosus?
Is
the flexion of the knee and extension of the hip.
What else?
And
medial rotation and lateral rotation. Biceps by lateral rotation and
lateral rotation by biceps and medial rotation by yes.
واحد بس يجاوب. Okay, again.
Okay, all the
hamstring muscle itself in general by doing extension of the hip, flexion of the knee.
Yeah.
Okay.
Yes.
For every muscle, what is the action?
Knee.
يلا.
So semimembranosus and semitendinosus cause medial rotation and biceps lateral rotation.
Okay. Okay, what else? Wait. Okay. So identify iliotibial tract. What is the function? What is the muscle attached to it? What is the muscle attached to iliotibial tract?
It's two muscles, gluteal maximum and tensor fascia lateral.
Okay. Saeed, identify common peroneal, head of the fibula, semitendinosus, semimembranosus, and what is the function? Discussed. Head of the fibula also will be asked. If we have common peroneal nerve injury, what happened? What is the value?
Ankle drop.
Root value.
Yes.
Root value.
Of what?
Common peroneal.
L4 to S1.
L4 S1. Yes. Common peroneal. Yes. The root L5.
لا اكتر من واحد. common peroneal.
common peroneal L4 L5 S1. Yes.
L4 L5 S1 S2.
S2.
Like that.
Okay. No. Static L4 L5 S1 S2. Yes.
static L3 L4 5
S1. 5 في 5 في static 5.
اسكت root value. نكمل بس كده يلا. Okay. Common peroneal nerve injury, you will tell about motor and the sensory, and you will tell about the division. Common peroneal can be divided into superficial peroneal, deep peroneal. Superficial peroneal supplying the lateral compartment, so loss of eversion, and sensory of superficial peroneal is dorsum of the foot away from the first web space. While deep peroneal supplying the anterior compartment, so if injury have a drop and absent sensation in the first web space. This will be the answer. Okay, root value خلاص. What is the muscles of anterior leg, posterior leg? This is a compartment. خلاص very easy. This is question. طيب خلصنا مريح لسه. معلش مريح شويه. اصل اللجنه دي فيها ابديتس. اللجنه دي فيها ابديتس. Okay. This is the picture came in exam. This is the picture which came in exam. انا خايف اوريكم حاجه، ما انا مش مطمن ان كل حاجه بتتسرب، كل حاجه بتتسرق. This is the picture.
This is deltoid and
This is the picture.
fibulatalar.
ماشي سامي. This is the picture came in exam.
Lateral collateral ligament, yes.
ايه مش فاهم.
This is lateral collateral of the ankle.
Which one?
It's first one you share.
لا خلاص، ما ده خلصناه. I am telling this is the picture came in exam about the name of the muscles here and the identification. طب اكون اوضح معاكم اكتر، استنوا بقى كده. معلش يا ماريا، اللجنه دي مهمه، معلش.
طبعا.
This is the picture in exam. This is from the exam itself. حد يعمل زوم بقى، هم صورتين دول. This is the two pictures. Identification
Yes, دي اللي جات لي فعلا، دي اللي كانت جات لي فعلا.
ما هي دي
دي جات لي انا في الامتحان ده اصلا.
This is the picture.
كانت زي دي تقريبا.
هي ديت يا ابني، متصوره من اللجنه، هي متصوره من اللجنه. اوكي. So these are the two pictures for this station. We have been finished of this station. دكتوره ماريا، يلا go for next one.
Okay, can you tell me the root value?
L4S3.
Okay. Surface marking in the gluteal region.
I think it's a curved line between 3 points, the posterior superior iliac spine into the ischial tuberosity, and then line also towards the greater trochanter.
Okay. Can you identify the gluteus medius?
Gluteus medius should be number 2.
Can you tell me the origin and insertion?
So it's from the ilium between the anterior and then posterior iliac tubercles, and then it's inserts on the greater trochanter.
And the nerve supply?
So be the superior gluteal nerve.
Okay, the root value, the nerve?
I think it's L4S1.
Yes, that's true. What's the action of gluteus medius during walking?
Should be abductor and extensor of the hip during walking. It keeps the contralateral hip prevented from falling or dropping during walking.
Clinical test if the gluteus medius is weak?
It should be a Trendelenburg test.
Okay. Other causes for positive Trendelenburgs?
We have few causes. L5 radiculopathy could give you that. You could also have diabetic neuropathy. Unequal length of the legs could give you that as well. And then we have developmental displays, developmental problems of the hip as well.
Most importantly, fracture hip.
Hip fracture.
Name of the hamstring muscles?
We have the semitendinosus, semimembranosus. We have the biceps of the femoris.
Okay. Action of the hamstring muscles, each alone and all together?
Oh. All together, they flex the knee. The semimembranous alone should I don't know them individually. Yeah.
Okay, so the altogether cause flexion of the knee joint and extension of the thigh, right? And the biceps femoris alone, it rotates the hip and and the knee externally, while the semitendinosus and membranosus rotate the hip and the knee medially.
Okay.
Okay. Okay. Can you identify the structures on this picture from 1 to 8?
Yes, I could try. So number 1, we're looking at the back of the leg. So number 1 should be the semitendinosus.
No.
No, the biceps femoris, sorry.
Yes.
Yes, and number 2 should be the semimembranosus. Sorry, not number 2. Number 2 is semimembranosus. Yes.
No. Wait. Yes, that's true. Number 2 is the semi-membranosus. Number 3?
Number 3 should be the semitendinosus.
Yes.
Number 4 looks like the gastrocnemius, maybe.
Yes, the medial head of the gastrocnemius.
Number 5 is the lateral head of the gastrocnemius.
Okay.
And then number 6 should be the common peroneal nerve.
Yes.
Probably. Number 8 probably is the popliteal artery.
Yes.
Number 7 looks like a nerve, probably. I don't know if it's a sciatic nerve or the posterior tibial nerve.
Yes. Okay, what are the structures in the popliteal fossa?
So structures in the popliteal fossa, we've identified some of them. The popliteal artery, we have the posterior tibial nerve. Most likely we'll have some posterior vessels, veins, and arteries. And we might have some lymph nodes and soft connective tissue as well.
Okay, so the common peroneal nerve, tibial nerve, popliteal artery and vein, the lymph nodes, the small saphenous vein, the posterior cutaneous nerve of the thigh, and the genicular branch of the obturator nerve.
Okay.
Which structure is at risk in case of supracondylar fracture?
It's probably the deeper structures, popliteal artery.
Okay. Causes of this swelling in the popliteal fossa according to the structure of origin?
So a nerve could possibly give you a neuroma. The veins could have varices, artery could have an aneurysm, soft connective tissues of fat, you could have a lipoma, and from the fluids, you could have a Baker cyst.
Okay.
And then
from the bone, we can have a tumor.
Yeah, sarcoma.
Yes. Okay. Drainage of the popliteal lymph nodes.
Essentially, they all drain into the inguinal lymph nodes. We have the efferent and the afferent lymph nodes. The efferent drain the superficial part of the lower limb, and then the afferent drain the deeper part.
Okay.
What is drained into the popliteal lymph node? This is a question.
Yes. What goes into the popliteal lymph node? Which parts it drains?
I'm not sure.
The small saphenous vein, the deep areas of the leg and the foot, and also the overlying skin.
Okay.
They are waiting, by the way, deep areas of the leg and foot. Don't forget small saphenous and the deep areas or deep compartment of leg and foot. Okay.
Okay. Thank you.
Thank you, Dr. Mark.
Also regarding of biceps femoris, and they will ask about hamstring muscles, and they will ask about hamstring muscles, action in general, and action of every muscle we discussed in previous one. By the way, when we'll come for the previous station about the common peroneal, concentrate, because they did zoom on the knee from behind. So identification first will be common peroneal, will be injured. So if you don't know which nerve, tell common peroneal. Inshallah, it will go. Yeah, it will ask you what is this. So because the feedback came for previous station about the picture of the back of the knee, they did zoom. So you will find all the picture about back of the knee, it is zoomed, and it will be difficult. What is this? So from the beginning of the station, you know that you will have picture for back of the knee. So the first structure will ask you about the nerve, it will be common peroneal. I think we covered all the updated questions. اعتقد مريم احنا نسينا حاجه، انا ما اعتقدش بصراحه.
هي mainly كانت الصور الجديده يعني لا اسئله بسيطه خالص في اللجنه دي بالذات واللجنه بتاعت الشولدر.
Okay. Great job, Dr. Maria, by the way, and great job from all of you.
Thank you. Yes, they did a great job.
They did great. Anyone feeling to be depressed, especially if we're going for a February exam, if you are feeling depressed, the level is very high and I am away. No. Study anatomy from this book. You have 3 hours and tomorrow 3 hours. Keep them by your heart, and inshallah you can score at least 17 or 18 in this station. Okay. شكرا يا شباب. We'll see you tomorrow. I don't know who will be with me, دكتورة سوزان or دكتور مراد. I don't know. شكرا دكتورة ماريا، عطلناك النهارده معلش. روح enjoy.
خلاص، thank you.
شكرا على خير. مع السلامة.
Thank you.